Now off. Good. Check. On or off? Open? Huh? Okay?
There is any mic on right here.
بسم الله.
change camera feed live دكتور.
بسم الله الرحمن الرحيم. يرفع الله الذين آمنوا منكم والذين أوتوا العلم درجات والله بما تعملون خبير. صدق الله العظيم. الحمد لله جليل النعم باعث الهمم ذي الجود والكرم، والصلاة والسلام التامان الأكملان على أشرف الأنبياء والمرسلين سيدنا محمد وعلى آله وصحبه أجمعين. أما بعد، حضورنا الكريم أيها السيدات والسادة، السلام عليكم ورحمة الله وبركاته. أسعد الله صباحكم جميعا بكل خير، ومرحبا بكم في ثاني أيام المؤتمر السعودي الدولي الثالث للمختبرات الطبية، والذي تنظمهم فرست أرابيا بإشراف الجمعية السعودية للحساسات الطبية وبالتعاون مع الجمعية السعودية لعلوم المختبرات الإكلينيكية والجمعية السعودية. الحضور الكريم. He is a professor and consultant in medical laboratory sciences at Al Majma' University. We'll be talking about treatment of dementia after stroke. Please welcome Professor Ra'ad al-Baraj'i to present his speech.
ايش هذا ضرب هذا؟ بسم الله الرحمن الرحيم. السلام الله وبركاته. First, I would like to thank you to allow me to speak about my presentation regarding about the new therapeutical of the stroke. It is preventing drugs. First of all, we need to classify my lectures. To let people to understand the lectures, we need to know the problem. After that, we confirm the problem. Let us explain. The problem is about the C-reactive protein, which is anti-inflammatory things. It's secreted regarding to the any inflammation. This C-reactive protein, these 5 molecules, when it is accumulated, it is changing to 1 molecule. We establish that as monomeric C-reactive protein. This protein, when they accumulated in the nerves, in blood vessels, it causes many damage. For the brain, it goes to have Alzheimer's disease. That's why we are talking about the things before they accumulated. يعني نتكلم على المشكلة. The problem is the C-reactive protein. Can I have next slide, please, to show him? We're going to show you the C-reactive protein first. Then we confirm the accumulation after the stroke. Means we need to show you the problem Can I have the next slide, please? أيوة الله أنا أيوة. Sorry. يا عم إيش ماله؟ Sorry for that. مش عارف إيش ماله. كيف؟ Okay. Let us talk because maybe the remote is not working. We need also to classify. We will see that the accumulation of the C-reactive protein. Secondly, we need to develop the scientific of the antibodies. قبل طيب خلاص. Let us start from beginning. أيوة. Okay. We have the slides. This is the C-reactive protein. This is the 5 component, and this is the things when they accumulated in different part of the body. We will focus in the brain after stroke. طيب, you know, we need to go for stroke. Anyone have a stroke, after 2 to 3 years, they will get Alzheimer. This is hypothesis, yes. We need to confirm it. To confirm that, we got a patients, dead, who has Alzheimer after stroke in Preston Tissue Bank. We get that, and we have ethically formed to examine, to see they have accumulated monomeric C-reactive protein in the brain. Okay, we got them, we classified them, the Alzheimer, the vascular, and we show also we got another patients also from Manchester, and we have these tissues to be examined for histological testing, and we stain them. I will show you the staining. Before I want to show you the staining, we want to confirm this accumulation in the brain in the part of beta amylase and B2, where's the place of the accumulation of monomeric C-reactive protein. طيب. See, this is the first stain. By the way, I am Professor Radi. This is my part, because this project is being done with a huge group of work. But in histology is my part which I involve. But I will explain to you the whole project, but I would like to thank them because this is a huge work I will show you, and I would like to thank my team. I am just only presenting all the work, but my specialize in histology. This is single staining of immunohistochemistry for monomeric C-reactive protein. We got the antibody from USA and from Manchester, and we stain the brain, the dead brain. We got them from Preston and from Manchester. We stain them for antibody to see the accumulation, because this patient is being recorded. They have stroke and they have Alzheimer's disease. And we found the human tissues and this big ethic form. We find the accumulation. How can I error here? By the error, you see the accumulation for immunohistochemistry in the place, and we use the antibodies M8C10, which is specific antibodies to be targeting the monomeric C-reactive protein. This work is a huge work. We publish it, but I am not involved of that to establish the antibodies by Professor Marcus Levin. But we confirm the accumulation, okay? This is the first step. We don't go for the next step. We are just starting the patients who died from Alzheimer, and he has a disease of Alzheimer, and he got in history, he got stroke. We confirm the accumulation. This is the problem. We are talking about the problem. This is double stain. Why we make double immunohistochemistry stain? By the way, we are laboratory, and this is the techniques to be stain immunohistochemistry in 2 positions. And this technique I learned from Manchester. The antibodies in the place of B amyloid. Why? This is the targeting where the monomeric C-reactive protein is accumulated. And the other, black blue, we already, the rounding of the nerve in gray matter to see the position. And this work, it's done by me, but they need a pathology to read the result. See how the project is very big. It is not me, I am presenting the results only. But this work is, I will acknowledge all the people who work with me. Also here, we do targeting the area of infraction, where is the stroke came. And we stain it with P amyloid, and as we say, we got the antibodies from Manchester who designed the antibodies to be stained as immunohistochemistry. Okay? We are now, I'm summarizing because I need you to be sequenced with me. We confirm, I will show you the result. It's been published in Q1 at the end. Have stroke, accumulation, confirm the accumulation in the brain. Okay, that's the problem. Next. Also, we have also here accumulation in B2 as arrowing to see the area. Now we have the problem. We know we need to solve the problem. This result has been publishing as research because I'm gonna get a point of the patent. We already established patent for this work. People is doing many research, and he published it in high impact factor, but we reach point to get a patent. This is also by different techniques. We already having the gray regions to establish and confirming the result, and we already publishing this result to establish. We establish first C-reactive protein, which is one molecule and it's accumulated in the brain. This is the result. We explain it to you. Okay? We see the accumulation, depositing the regions in P amyloid and TOU, and we confirm that the accumulation is happen from C-reactive protein, which is accumulated as in monomeric C-reactive protein. Halas. Now, we need to go to the next stage. What means next stage? We need to confirm it because we get from patients who died from stroke, Preston, tissue bank, human, blah, blah, blah. Now we want to be in vivo. We cannot start in human. We cannot start in human. We'll start in mice. Let us see what we are doing. We get the mice, and I'm showing you very small film. We get this mice, we put him in water race test. Means what is water race test? It is pool of water and we throw the mice. معلش في بلاعة بتكون في الووتر ليز. I don't know what's in English بلاعة هذه اللي بتطلع فيها بتهرب من الفار. بالانجليزي مش عارف شو يعني بلاعة. طبعا حنشوفها حتلاقي الفار the mice will run and then he will find out the way go out. I will show it to you. Then we inject the mice within hippocampal regions to get stroke. After 3 months, our hypothesis is the monomeric C-reactive protein will accumulate it in what we mentioned as we discuss in human. We want to confirm it, to get this mice as Alzheimer. He will not know the way how to go out, or he will يعني حيغرق. After 1 month, شهد ready. هذا هو البرنامج. هنا قبل ما يصيبوا الخرف حنحطه في المويه حيعرف وين. الفيلم الاولاني ولا الفيلم الاولاني؟ لا روح ورا، لا باك يلا هنا. ايوه شوفوا كيف حنحط الفار. طبعا هلا حنتكلم لازم يصيبوا الزهايمر. يلا اشتغل، ايش تعذر؟ يلا ايوه يلا شغلوا، اشتغل معنا هلا قبل شويه. ما اشتغل، لازم اشتغل، شغلناه الصباح. اضغط عليه. ايوه شوف الفار، يلا مش عارف تولح. لا حول ولا قوة الا بالله. اوكي طب go for the second film, the other one. طبعا بعد ما حقناه ايوه هيشتغل. غريب الصباح اشتغل معنا يا عبد الرحمن. طيب نشوف الفيلم الثاني. طيب سبحان الله ما اشتغل الآن، كان اشتغل الصبح. يلا طبعا الفيلم احنا بنحط المايس ريز تيستينج. you will see the mice will moving around and he will find the way where he go past before. Yeah. The second test, which will be after injecting him in hippocampal وصابوا الستروك حيصيبوا الزهايمر. كيف حيصيبوا الزهايمر؟ It will accumulating the monomeric C-reactive protein in his gray matters in B amyloid. طبعا كل هذه هايبوثيسز، بس الفيلم هذا عشان نشوف الفسيولوجية كيف صابوا الزهايمر. طبعا ما حنسويها في بني آدم، هذه موضوع تاني. احنا حنسويها في المايسز عشان نعرف انه how he cannot be able to see the way. خلاص طبعا هذا كله كلام physiological. We sacrifice after that the mice. شوف النكست سلايد. خلاص ما راحت علينا. طيب sacrificing the mice and we get the brain and we stain them in the same antibody we established in Manchester to see the accumulation. Is this any accumulation in the C-reactive protein on the beta amyloid? We confirm in different stain in immunofluorescence the accumulation the same as the dead human sample we tested. خلاص الآن احنا we move from dead tissue bank for human we do mice in vivo, we confirm the accumulation of monomeric C-reactive protein, and we test it in mice. We get the sample, we localizing the problem of the accumulation in B2 and in CD105 antibodies, which is the localization of monomeric C-reactive protein. .com. الآن طبعا هاي الشو results وورجيتكم اياها. This all results we publish it in scientific report in Nature in high impact with Professor Marcus Levin, who is my supervisor in Manchester, and we have also Jerk Skarbuksi in USA. As I say to you, this work is not only me, it is a huge work with different people. I am just explaining the results for them. We publish it in different high impact factor. طيب, now we need to solve the problem. خلاص هاي research. We need to solve the problem to establish something to stop the accumulation. هنا موضوع البراءة, the invasion. عشان تسوي establish لأنه في عندك مشكلة, we have accumulating after the stroke, والميديسن أنت بدك تسويه, you need to have establishing and تشيد antibody who goes to be amyloid TAU, the place where that to be accumulated. We need them to stop by establishing. This is the antibodies. يا ايش مالكم انتوا اليوم علينا؟ الآن the antibodies we establish it. مشكلة معكم اليوم أنا. establishing the antibodies هذه في الهاي واللايت. طبعا أنا هيستوباثولوجي, في فريق تاني immunology وفي جيرك كاربوكسي في أمريكا قعدوا هم يصمموا لي هاي تشين ولو تشين. طبعا أنا كنت معهم بالفريق, أنا كنت معهم بالفريق, بس أنا هعطيكم الريزلتس إيش سووا, بس أنا ما سويت الشغل هذا عشان ما حدا يتكلم عن حفظ حقوقهم. طبعا establishing هذا بفهم immunology, تخصصهم immunology في اللاب, بفهم اللايت تشين والسلسلة الثقيلة والسلسلة الخفيفة, وقعدوا يصمموا عشان يكون الاتاتشنج في الريسبترز على مكان الاميلويد, عشان يجي المينوموريك سي رياكتيف يتراكم, ما يقدر يتراكم. فهذا هو البراءة اللي سويناها احنا. We need to explain. I will explain to you the way of that to be stopping, and we publish this result, and I will tell you what is problem we facing for the new therapeutical كمان. بعدين what is the second choice, because I just been doing this work since 4 years and a half. This is not for 1 year, this work for 4 years and a half, and I cannot say jumping to you to what I have been done for the antibodies. I develop it. We need to explain to you, and this is the monomeric therapeutical for stopping the signaling pathway. طبعا ما هو لما يقفل بده يقفل لك السيجنالينج باثوي للاكوموليشن بالإيرك 1 والإيرك 2. We need to confirm it. I have some results in PCR to confirm that. I will show you at the end the result for that, as they're stopping the accumulation of the antibodies we develop it. طبعا التارجتينج كان فينا ريجونز اللي حتكون سيل ميدييتد, انها ما يصير لها accumulated in the specific regions for them, and after that we optimizing the antibodies. This optimization, Abdurrahman Bazed, he asked me how to optimizing. This is another technique of optimizing the antibodies for the FC gamma antibodies, which is another group to be specify the antibodies to stop the accumulation. And this work, I can show you the results which be publishing in some high impact factor with my groups. طيب, a proof of study الآن. سوينا الميديسين وشكرا جزيلا وتمام وكويس وخلصنا وطلعنا وحوريكم طبعا سجلنا البراءة وطلعنا الباتنتس. We already, I can show you the patents, and this is another story. I show you the certificate for the patents because I don't want to tell you something and which is also having no proof of the study. We did also gray matters, and we stained them with our antibodies, and we add monomeric C-reactive protein in histology by techniques called double sandwich, and we are proving that the antibodies cannot be stained in the mice and human tissue from breast bank. طبعا, this is the antibodies. This work, maybe genetics people or immunology people knows. And this is the targeting, which is based in sequences for antibodies. And this is, by the way, when you have the patents, we have to add this in the patents to get the patents to approve this sequences, which is people who do the work. This is the antibodies which we already establishing as drawing up to show the monomeric C-reactive protein is attaching to them and does not be accumulated in blood vessels or in the nerves and blah 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 for accumulation for monomeric C-reactive protein. This type of paper we establishing, we got more than 18 paper for that subject, which I got in C-reactive protein accumulation, glycations, establishing. Huge work is being done with very high people. This is all the paper in Q1 is being publishing, and this is the certificate of the pace. When we apply it, we already go in international, and we get the first prize by 25,000 in Kuwait in 2000s, and prize from a research group. And this is the acknowledgement of the people who work with me, Professor Mark, Dr. Riyad Abdurrahman, Dr. Ali Shankiti, all this of the people who work with me. I need to show the certificate of the patents. طبعا future work هكلمكم عليها future work, what is the next, but I want to show you the patents because this patents is approved, and this is the certificate. Can we go down? This is the group of people who work. The type of patents is being certified from King Abdulaziz, and also we apply it in UK. Still 3 years not approved. We approve it in Saudi Arabia because in UK they take lawyers and to approve it. This is the certificate. I can show you. This is. Can you go a little bit small? This is the problem we explain. Go small, a little bit small. This is هاي بسموها خلفية الاختراع، تتكلم عن المشكلة. Go at the ends and then الأشكال، المضاد، الأشياء طبعا كلها you have to explain it. This is the test for optimization of the antibodies. This is the work of mice, histological work of conformation test, the angiogenesis of that. We have to explain that and from the down, but I want to go for the patents, which is giving me the invasion, is the sequences, the antibodies sequences أيوة of sequences of the antibodies which is being confirmed the patents. Now at the end, future work in the groups, two ways now, and we don't have funding for that, by the way. We need to, because the antibodies, when we, now I'm going now, what is side effect of the antibodies? We're talking about the side effect of the antibodies now. You have patents and you have medicine, and you say that you have medicine to treat the Alzheimer, the stroke patients to not get the Alzheimer. But what is the side effect? A huge of side effect. Before I explain to you the future work, these antibodies will work only for 24 to 48. After that, you have to inject the patients every 24 to 48, because this blockage will go and the signaling pathway will go. Now I am putting myself in trouble. I know, because we go to pharmaceutical company, Dubai Vises, he gave us huge trip, 5-star. But we find out they have a lot of side effect. They say to me, Prof, with my group, you cannot have this. You have patents, but it is to make it, to inject it to human body, a huge work. You have 1, 2, 3, until he gave me 42 side effects. I just been silent. I said that now, you want to help us or you want to stop us? He said, no, we need to help you, but this, to make it as medicine, preventing medicine after stroke, and your antibodies, you establish it and you put it in mice. You don't know what's the side effect. This is the side effect. You have to have it. One of them, they go, some of them, they destroy some type on liver cells. He gave me a huge list. I said, what is the next? I need to do something to have this patent. He said, sir, you want to go for diagnostic kit only now. They shift me. He said, you have invasion, just only you can go in human to establish a kits, and this kits you have to put the serum and see the level of accumulation for the human patients to say he is in dangerous, he will get Alzheimer. And they shift me to China. I don't want to tell you the stories. That's why we say maybe we need some power, government power, to establish this medicine. Because they ask for money, I don't believe it. Billions. He said, we need to have patients, and this patient has to be sacrificed to inject him with antibodies, and then we need to monitoring him. I said, stop, we're gonna go for the next, which is who has no side. This is the future work. We need to establish the antibodies which is attaching the monomeric C-reactive protein in the blood before the accumulation, and we need to dissolve the monomeric before its accumulation, and can goes with less of disadvantages. This is being establishing in Manchester. We are looking for fund, and some people said to me, we can do this one in T3, T4 for the thyroid to stop the secretion of some hormone. Another hypothesis, we need to work on it. The final, before I close, anyone has doing a research, he can have way in laboratory to establish invasion. And this is all my work in laboratory. I'm gonna give another talks in cholesterol level of measuring, and it's starting in research and ending in the patents. I would like to recommend that for the researcher in clinical laboratory scientist. Thank you for listening. Any questions? I am sorry I don't explain to you some results for colleagues in PCR and confirmation about this one because it is not my subject. I told you I am histopathology in tissue. Thank you. Any questions, any suggestions, any cooperation for funding? As I told you, I am willing to work with anyone of that. Thank you. I will see you in cholesterol. Also, I have lectures and invasion of that, and I can. But I'm sorry. I have 4 invasion also. I will explain it in future talks. Thank you.
ألو. شكرا للبروفيسور رائد على هذا العرض الرائع. أيها الحضور الكريم، ننتقل معكم الآن إلى المحاضرة الثانية لهذا اليوم بعنوان Diagnosis of Infectious Disease by Immunological and Serological Tests, will be delivered by an Associate Professor of Immunology at Al Qura University. Please welcome Dr. Amna Abdullah Al-Ataibi.
Assalamualaikum warahmatullahi wabarakatuh. First of all, I would like to thank the organizer for having me here today to sharing my knowledge and my experience in immunology in lab with you and with the audience. And secondly, I would like to thank the audience who are here in sit or online, and I hope you're enjoying my speaking today. I would like to talk first about the diagnosis of infectious diseases, how to use immunology and how to use serology to find and diagnose the infectious diseases. First of all, that is outlined for today. I will go through how explaining and understanding the basic immunology and immune system and how it's works, and use that in the lab and also in therapeutic field. As we see before, the Prof. Right for the start, he used immunology, monoclonal antibody as a therapeutic approach, and C-reactive protein, which is one type of immunological response as a reactive protein in inflammations. And then I will give some example about serological examination, how to use it in lab, what the advantages and disadvantages, and how we use that to improve the quality and how to use it in the right way, in high quality way to reach to the diagnosis. And I will end with the recommendation and some tips how to maximize the accuracy in serology lab and in immunology lab as well. Let me first take you in the journey for the immune system. What's the immune system? Immune system basically consists of the organs and tissue and cell and organs and soluble materials. They work all together to fight infection, eliminate infections such as viruses, bacteria, or fungi, and also the tumor cells when any abnormality happens inside our bodies. It consists from primary and secondary organs. The primary organs is responsible about generated the T cells or B cells, which is bone marrow of the thymus. And the secondary lymphoid organ, which is spleen or lymph nodes, which are responsible about where the immune response take place. When say immune system, I'm sure about it, most of us comes to our mind, WBCs, which is the leukocytes, is a take part in immune response. When I say immune system, I'm talking about the system and organ. When I say immune response, that's what's happened and defense mechanism happen inside the body when seeing antigen or pathogen for the first time. We have two types of immune response: innate immune response, and another one is adaptive immune response. How the immune system seeing the antigen? Your immune system see it as a foreign antigen, so it's protein reaction with the protein. Antigen, recognition, response, and then give the reaction. For innate immune response, that is the first from the zero time when the infection is happening. So the cells that involve is the neutrophil, phagocytes, and monocytes, eosinophil, or basophil, or complement system. All of them together work to eliminate the infection. However, this response, even if it's rapid response, it's non-specific and non-memory. What I mean by non-specific, it's looking just for a pattern. So we see that is a pattern for bacteria, it's a bacteria. Don't differentiate it between a gram-positive bacteria or gram-negative bacteria. Looking for the pattern of the viruses is just in viruses. Don't know it's HIV viruses or influenza viruses. So it's non-specific response. Non-memory, what I mean by that, it's non-memory for this is viruses or bacteria. Every time the infection happens, that immune system see it as the first time. However, the adaptive immune response, which is basically deep in B lymphocyte and T lymphocytes, are more specific and also more highlified and qualified. How the specificity happen, and B cells, when it's activated, become plasma cell, give us antibodies. A T cells, when it's activated, is release what we call them in immune system cytokines, which is a protein as a response, and that's activated serial reaction in the cell and give us a response. How that translated? It's give us a memory. What I mean by memory, if the viruses enter the second time or the bacteria second time, the innate immune response do not do the job. The job is done by adaptive immunity. So how I differentiated between them? In innate immune response, the usual individual have a sign and symptoms, fever and cough and so on. But in adaptive immunity, when the second time is happened, here what we call them immunity is already generated. So what's happened? No sign, no symptom, the virus is already eliminated because of antibodies. That's understanding the basic how the immune system is help us in industry to develop the vaccine, and also to develop a technique that can use in the lab to diagnose the infectious diseases. When it comes to response to the immune system, how adaptive immunity is work by what we call them humoral immunity and cell-mediated immunity. And humoral immunity is responsible for extra microbe. Any microbe that extracellular, not inside the cell, is taken apart. And monoclonal antibodies is the main side here is the work, the job. And cell-mediated immunity is take a huge part in the case of intracellular infections. So we have two main cells. First, the phagocytosis. The phagocytosis is innate immune cells. However, the T cells, when it's activated, is direct them to go to the specific viruses, specific protein, which is a receptor or epitope, and react with it. The same thing with the viruses, such as RNA viruses, DNA viruses, all of we, as we know, viruses intracellular pathogens. So we need cell to go inside the cell, infect that cell, and the cell is changing from normal cell to abnormal cell or infected cells. Here, that activated what we call them cytotoxic T cells is killing. So go to the side to abnormal cell and eliminate the cell and the viruses from that cell. Why I explain that here today in immunology diagnosis? Because that takes me to answer that questions. How can understanding immune system use it in industry field? I can use it in diagnosis, I can use it in therapeutic, I can use it in following the patients. So both that criteria, when understanding immune response, is direct me for future to save the people. First of all, in diagnosis area, I understanding how the cells, each cells play a role. For example, in case of a bacteria infection, I recommended will find neutrophil is high. General leukocytosis, however, neutrophil basically is the one parameter high. So that directs me, that patient have a bacterial infection. However, in case of the viral infection, I will see lymphocytosis. So that will take me to this part. Parasitic infection, eosinophil and basophil will play a role here. On another side, in adaptive immunity, antibody, I use it to make a technology that I use in the lab. I will explain it later on, inshallah. A cytokine or so that mediator an environment of reaction, I can use it and detect it to understanding there are inflammation. One example, C-reactive protein, which is an inflammatory marker, or interleukin-1, TNF-alpha, all these is a cytokines. Antibodies are secreted from B cells. It's play a major role in activating, it's play a major role in the case of protections. How that's happen, I will take you a little bit about the antibodies reclassification. IgG, IgE, IgD, and IgM, IgA. Why I explain them one by one? Because everyone that have indicator, IgG is have some indicator. I will explain it later on, inshallah, today. IgE, we will see it in allergy, and so food allergy, parasitic infection. IgG will I will explain it later on when they come in the sessions. IgA is find the secretion, GIT, or respiratory tract system. So understanding the place where it is, that's helped me to choose the right antibody in case of diagnosis, and the right antibody in the case for the treatment therapy. I mentioned that already. Understanding that develop a vaccine, that means a prevention, that means security, that means there is no more infectious diseases. That's to take you remind to the COVID-19 and what's happened. After the vaccine is developed, the rate or the decline of the care for the infection is decreased. By developing the basic and immunoglobulin and the IgG developed in the lab. That's how your immune system is response. If you see here, when the virus enters the system, incubation period, no antibody can detect it. So in this case of the time, when I do diagnosis in lab, will give me false negative result. Why false negative result? Because the virus is still in varied doses, not replicated a lot, not immune response adaptive immunity taking place. In this case, molecular immunology will take place, PCR. So we will see how the doses of RNA replication to diagnosis. After 7 days, when the immune response, the first immunoglobulin I see is IgM. So Ig mean acute infection, recent infection. Just happened now. That's the indicator for IgM. After 7 days, when IgG is developed, that means this is still past, this is infection in the second stage, and the immunoglobulin IgG is increased. That means the care taken the protective. What's meant by protective? IgM will decrease, and then the viruses will decrease level as well. IgG, it stay in our body forever as a protective. So that's how the immunization is happening. Infectious diseases تعريفها, it's a common disease caused by different pathogens, causes infection and epidemic in the area. Infectious diseases, third for the people life, can cause a lot of the death rate. Could be viruses, could be bacteria, fungi, or even helminth or parasitologists. Based on the study and research published about the infectious diseases that causes a high mortality and morbidity rate is based on the viral infection. I think one of these viruses is coming to our mind. Ebola viruses, SARS, MERS, HIV, hepatitis B viruses, Z viruses, H1N1 influenza viruses, and COVID viruses. So that's why the rate of the infections is very high, viruses comparing with other type of the pathogens. Then, after I give a little bit introduction about the immune system, that's make it easy for me when I'm talking about how we can use the tools, the diagnostics in the lab, to diagnose the infectious diseases. In case of the serology, when I'm talking about just serology identification in the lab, that's taking me to the three important. Could be by direct way, microscoping or staining, could be by pathogen isolation, which is a PCR, and the final way the diagnosis of infectious diseases is serology. What I'm looking for is antibodies in these cases. So let's take you again about the serology and immunology, because most of the people confusing between these tests in the lab. There are different between serology and immunology. When I say serology, that means anything in the serum, antibodies or protein or any marker in the serum. When I say in immunology, is that the science that takes place studying the immune system, how it works, what is the disease and disorder. It's not in sera. In general, principle of serological test is one of them is noun and one of them unknown. There are a good relationship between antigen and antibody. So in the side of human being, during the infection, antibody move to find the antigen. When the antibody find the antigen, a reaction is happening. When the reaction is happening, we call them immune complex. So that is how they react inside the human being. In the lab, how I can use this, I can make them noun and one them unknown. For example, if I would like to detect antibody in the patients to see it's IgM breast infection, it's IgG breast infection or chronic infection, I will take the serum from that patient. So the antibody is unknown, and I develop the technique in the lab. I know the antigen. So the antigen is specific of hepatitis B, hepatitis C, HIV, influenza H1N1, based on epitope or peptide. What does it mean, peptide? The DNA sequencing showing in the surface of that viruses. So that's the antigen noun, and I take that in the technique and put it in the lab for detecting the antibody. The outcome of that result, I will say that is positive for infection or negative from that infections. That's take me to say about the applications in the clinical lab. So I can use this in infectious diseases by direct or indirect way. I can use it to know in what severity of the stages. For example, some of diseases such as autoimmune diseases or autoimmune diseases, the patient on the treatment. So I would like to know in what stage is that treatment. Serology can help me to do that. If I do the study, epidemiological study, I do screening. That screening, it will be looking for antibodies, which is serology again. Diagnosis of congenital infection, and also screening for blood and tissue donation. All that basic, it's deep in one principle, antigen-antibody reaction. And so I can use it tumor, autoimmune diseases, and endocrine. TSH for thyroid to detect it is basically in the lab built up based on antigen and antibody reaction, which is serology techniques. Okay, it's finally, and it's brilliant, antigen-antibody reaction, but that's nothing for sure. There are some concerning about the antigen-antibody reaction. The relationship between antigen and antibody reaction is non-stable, so it can be separate and can be back together again. So something will really make us to sure about the lab, what we call them cross-reaction. Sometimes antibody can cross-react with non-specific antigen in some situation and environment would give me false positive result. Also, in the case of early stages of infection, serology cannot help me here because it can give me false negative result. Validity, when I develop any technique, I should know that that is valid. What I mean by valid? Specific antibody binding with the specific antigen and the binding between them in high affinity. That can help me to understand it. That will help me to know that have diseases or not have the diseases. In specificity, of course, كل ما كان التست less cross reactivity, that is most near to the true comparing with other tests. Sensitivity, serology test sensitivity is very low, so when I make it, I have to develop it to be detect a very amount antibodies or antigens. That is the technique. The most technique that's used nowadays in the lab and basic antigen antibody agglutinations is still popular until now. Hema-agglutination assay and hema-agglutination inhibition test. Labeled reaction such as enzyme-linked immunoscorbate assay ELISA. Immunofluorescence assay also still very popular. And the complement vaccination test. All these tests is just an example for the tests that used in the lab nowadays as antigen-antibody reaction to detect the infectious diseases. Can be used manual in some lab, and some lab is already developed that as an automation machine can use basic in the same principle. Why I explain principle before I go inside the test? As a lab technician, or lab specialist, or consultant, or manager, if I know the principle how the test is now working, I will improve the quality management in my lab, which give accurate and precise result that can help me to the right diagnosis and patient safety. Agglutination means aggregate, clumping. So some of an antigen could be practical, latex, which the other part is soluble. So how they react, one it should be practical and another one is soluble, react to other, and we see them as a clumping in slides or in tube sometime. So that reaction could be slide or could be in the tube. We use it as indirect or indirect, passive or invasive indirect. Could be coated the practical with another thing, use it in the lab. There are a lot of the type of latex can help me to make the reaction is more visible. All this is a technique that industry will provide agglutination to us. The reaction, and this one could be qualitative or quantitative. I mean, be qualitative could be positive or negative. Quantitative can give me a titer, so I know the titer for that antigen or antibody that I'm looking for. That is how it look like this one. Inside the tube, inside the slide, that's how the antibody and antigen react to each other. Doing that network, such clumping, that's mean positive result. If you see here, that is the antigen antibody make as a clumping. Why I highlighted that here? Because in the end of this slide, I will talk about the quality control, how I keep this in the right way to avoid positive and negative results. Example for agglutination used these days in the lab. We use it for direct bacteria, can use it from cultures or from lesions from the patients. Sometimes can use it in the tube for typhoid fever, replace it by another one. Indirect latex commonly used in microbiology lab. And so indirect hemagglutination is used for the parasitological infections. And direct agglutination for blood grouping. All this is the same principle. Some of practical is solid and another one insoluble. Soluble or insoluble react to each other, and I can see it in the tube or can use it in slide as a clumping reaction. C-reactive protein is still the most popular that one can use until now in the agglutination lab. C-reactive protein that usually release from the liver in case of the inflammation in the serum can help me to diagnosis. So when I do it, I have to take what we call them coated latex by anti-C-reactive protein. In the serum, there are C-reactive protein. They react to each other. We can see that reaction. I can use it for bacteria, rheumatic fever, TB infection, tuberculosis, malignancy, and follow up the surgeries. All that can C-reactive protein help me. Advantage and disadvantage for the lab. First, I'll go with the advantage. most widely used technique in diagnosis. However, it's easy, simple, but it's still, until now, some of concern about the accuracy of results, so we need some time confirmation, but some time of the test doesn't need a confirmation, even the clumping is clear for that reaction. And matching the sign and symptom with the requesting patient and clinical history. Disadvantages: low specificity, low sensitivity, result affected by vaccine-induced, subject error in reading, agglutination, antibody appeal late in the infection. What I mean by these things: specificity means sometimes false positive can happen. Low sensitivity in the case of early stage false negative can happen. Result affected by vaccine-inducing antibody. I mean, for example, if that patient taking the vaccine and they come to the lab to do the test, that can affect it in the accuracy of the result. Sometimes, if the area is not clean, a slide not clean, can reading subjective by the eyes, doing clumping, could be make a mistake. Agglutination antibody appeal late into some infection, so that cannot help me. The lab, I can decide it when I can use this as a screening, I will not can use it in non-screening. And it could be confirmation by another serological lab as ELISA, or could confirmation by CB. That's even in the requesting and in the diagnosis. Labeling reactions. A labeling reaction, that's take me to the ELISA. Mean labeling, that means something in labeling could be enzyme or could be radioactive immunoassay. The easy way for this one is something solid in the plate as a direct. When the direct not give us the impossible result, we move in the indirect. And that's have some advantages and disadvantages. The advantages for this one is quick. However, could be the labeling reduce the validity of antibody. Here is therefore development by this way. However, cross-reactivity could be happen. Therefore, the ELISA is developed what we call the sandwich ELISA. That's capturing antibody, that antigen what I'm looking for it, and that's the antibody binding and the confirmation by another antibody. So that is more sensitive compared to the old traditional way. And that's when competitive ELISA, when I competitive two antibody to bind with antigen, so one of them who high affinity can binding. That more sensitive, more specific, because the annually here is the affinity. Who is high affinity, who is the antigen, and usually the antibody come from patient serum, is usually come with a high affinity. When talking about serological, just I would like to mention the important for the viruses structures. That's an example here. If you're understanding the virus structure, there are surface protein, core protein, or envelope protein. Each of them antibody confirm that can be diagnosis for something and an indicator. Here the example for decoding. Here, surface antigen, IgG for core, IgM for core, IgG for the surfaces. If I do the test and all of them that negative, mean then that no infection, no vaccinations. If I see positive surface antigen plus antigen antibody against the core and antibody IgM the core, IgM plus IgG for the core, that means the still active, the infection. So the patient is not recovered yet. If I see in these cases, surface antigen absent, core and immunoglobulin IgG absent, a surface is also absent. Surface, when I see the surface IgG, that's mean protective. What's mean protective? For the surface, for the whole viruses, I can see it. IgM only alone, no antigen, that's confusing a little bit. It's infection there, but why the virus is not seen? That could be combined with another infection, for example, HIV patients. And the second one here, core IgG positive with surface positive, that means take place the infections and the immune system could the infection perfectly and it's a trend for the protective agents. Here, all the parameter negative, just the surface, that means that is have already vaccine and the vaccines do the job and the protective is here. Chronic hepatitis infection, if I see surface antigen, and IgG for a long time, that means the patient's immune system is still trying to fight infection, but not yet the protective is development. HIV, the similar thing, when talking about it, is little complicated if I deepen in serology alone in the case of the HIV viruses. So molecular basis is much better to do the PCR. The thing that I would like to mention here in HIV patients, it's what we call them, when I say that patient have AIDS, here, when using a parameter CD4, CD4 is a marker for T helper cells. If that under low 200 cells per cubic millimeter, that's we say this time I say that is have acquired immunodeficiency. But if above that one, we call them HIV infection, but not we call them as a condition diseases, AIDS or acquired immunodeficiency. So that is based on the guideline from WHO. I would like to sum up or enter with how to maximize the quality in the lab. This process is what happen in the lab. Everyone, I assume, in the lab know that one. The story is the start when the patient go to the clinic and the physician order for the test here should be the right test. If the right test is ordering very well, test selection is good. So that test processing will take that both of the way, starting from pre-analytic or pre-examination, analytic or examination phase, and post-analytic. This circle should be taken in a quality control management program, should be taken and considered in every step in the quality to reach the right diagnosis and give that patient of result. So starting from ordering correct test, go in the lab, correct the specimen correctly, and then analysis in the lab, following the protocol, the instrument clean, pipetting is a calibration, automation is a calibration, and then the result interpretation based on the doctor read it very well, and that's go. So in every step to maximize my lab work should be I pay attention for every one step as a quality control based on them. In serology tests, there are factors that play a role. Here, the story that I would like to do, say it before, reaction between antigen and antibody ratio. There are zones, we call them equivalence of the zone. That is the right way when the test is come quickly and diagnosis by the right way. In the case I do the sampling and the antibody more than antigen, or the opposite, the antigen is more than the antibody, that's what is happening. Pre-zone, false negative, post-zone, false positive. Should be the amount that I use in the lab, following the protocol to reach the equivalent of the zone. Time, temperature play the role, so following just the protocol and pay attention for this thing that could be affected the result quality. Don't forget the window period. Window period, the early stage of the infection, where cannot see the antibody, but the virus replication can see it easily by molecular medicine or PCR. That's some tips. I say it before, but just put it here to see by your eyes. It's just following the protocol, maximize the error as much as you can by following the quality control in the lab. I assume and sure every lab have their own quality system which can manage any error that can happen during the lab work. Thank you very much for listening, and I hope you are enjoying that sessions. And if you have questions, you can ask. Thank you very much. Do you have any questions? Okay, thank you very much.
شكرا جزيلا للدكتورة آمنة العتيبي. أيها السيدات والسادة، محاضرتنا الثالثة لهذا اليوم بعنوان Antimicrobial Resistance Among Europathogens will be delivered by an assistant professor at the University of Hayel. Please welcome Dr. Abdulrahman Bazaid to deliver his speech.
Good morning, everyone. And I would like first to thank the Saudi Medical Sciences Society for this invitation. This morning I will talk about a study we did in Hile about the antimicrobial resistant among uropathogen. First of all, I will cover some of objectives during my presentation. First of all, I will talk about urinary tract infection, and then what is the case of urinary tract infection in Saudi Arabia. Then we will go through a brief methodology. Then we will talk about some of the interesting findings that we found in our study, and then we will discuss the study, then we will conclude. Urinary tract infection is an infection, a bacterial infection usually, caused by bacteria which go through urethra, causing an infection in the bladder or in the kidney or in urethra or even in the urethra. The urinary tract infection is more common among female. This is attributed to the urinary tract system in female as is differentiated from male. That's why 60% of urinary tract infection is associated with female, especially young female. Urinary tract infection is a major infection worldwide. In Saudi Arabia, it accounts for only 10% of all infection. And usually associated with outpatient instead of inpatient or ICU patient. As I mentioned earlier, it's caused by bacteria. So a lot of bacteria can cause urinary tract infection. Mainly Escherichia coli, which is a gram-negative bacteria. Followed by Klebsiella pneumoniae, which is also gram-negative bacteria. Then some of the gram-positive can cause urinary tract infection. Here is an example of a study in Riyadh in 2008. As you can see here, Escherichia coli is counting for the major infection, urinary tract infection. This study has been done in urinary tract infection in outpatient. So as you can see, Escherichia coli is in the top and followed by other gram-positive and then some of the gram-negative. Then extended spectrum beta-lactamase bacteria will follow. So why we did our study? Because we couldn't find any information about the prevalence or antibiotic resistant rate in higher region. So that's why we decided to do a surveillance study of urinary tract infection in Hile. Our study is a retrospective study, so we collected a previous data from the lab. We collected data for 5 years from 2 major hospitals in Hile. One of them, the maternity hospital, which is a large hospital of around 200 beds. And then we included largest private hospital in Hile with 500 beds. This is like a major study in Hile that we include 2 largest hospital in Hile. So we collected the data for 5 years and then we analyzed So the data include the sample, which urine sample, the type of bacteria, the resistant profile of each bacteria, and then the type of patient, whether in or out patient, and it's also include the patient age, whether it's a new infant, a newborn, or an adult or elderly. Our study showed that majority of infection is associated with a female as suspected. Although our study include the maternity hospital, and maternity hospital is only for female because it's a maternity hospital. So this is one of the drawbacks of our study. However, usually urinary tract infection is associated with young female, as I mentioned earlier. Regarding age group, we found that majority of urinary tract infection patients were adult, and although usually elderly is associated with urinary tract infection, however, as I mentioned earlier, our study include the maternity hospital, so this is one of the drawbacks. That's why we didn't have a high number of elderly patients. Regarding the admission status, majority of patients were outpatient. Regarding type of bacteria, as you can see here, before type of bacteria, regarding the prevalence of urinary tract infection among years, as you can see here, the 2018 was the highest number of urinary tract infection, and 2016 was the lowest urinary tract infection in Hile. Regarding the type of bacteria, we can see here the stripe type of column. This is indicate Escherichia coli. We can see in all year Escherichia coli were predominant, as expected from other study, and then followed by Klebsiella pneumonia. Although the Klebsiella pneumonia percentage has been varied between years. Gram-positive bacteria formed almost a third of urinary tract infection among years. However, as you can see, the gram-negative is predominant. Let's talk now about resistant profile. First, we will talk about Escherichia coli resistant profile. This is the resistant profile among years. As you can see, the resistant profile of piperacillin is increasing between 2016 and 2017, and then a little bit reduction. And trimethoprim, we can notice that it shows a high resistant profile among Escherichia coli, and the resistant profile stable in 2019. The significant thing is about gentamicin. Gentamicin show a high resistant profile in 2018. 2019 among Escherichia coli. So majority of Escherichia coli in 2019 were resistant to gentamicin. Then let's talk about Klebsiella pneumonia. As you can see in Klebsiella pneumonia, 2016 show a high resistant profile to gentamicin, and also a high resistance profile to amoxicillin in 2016. The piperacillin also show a high resistant profile among Klebsiella pneumonia. I'm talking about the green bar in 2019, 2018, and 2017. So although there is a low resistant profile here, it appears to have a high resistant profile in the latest year. Lastly, we will talk about Pseudomonas aeruginosa resistant profile. Although Pseudomonas aeruginosa only account for low number of sample, however, Pseudomonas aeruginosa is causing a lot of problem in hospital and associated with high resistant profile. So as you can see here in trimethoprim in 2015, it was high resistant profile, almost 100% of Pseudomonas aeruginosa, and this also showed in 2017. So almost all Pseudomonas aeruginosa were resistant to trimethoprim. In 2019, we can see some resistant to trimethoprim. Although the other antibiotics show a variation, and this resistant profile goes down in the recent years. Our results showed that majority of gram-negative bacteria, including Escherichia coli, including Pseudomonas aeruginosa, show a high resistant profile to trimethoprim and also to gentamicin, as these drugs was used to treat urinary tract infection. Although I didn't highlight the result for gram-positive, as it's only account for a small portion of urinary tract infection bacteria, it caused almost a third of the cases, and this is the same trend as seen in other regions in Saudi Arabia, for example, in Al-Baha region. We conclude that drug of choice can be changed from trimethoprim to other active drugs, for example, meropenem. We showed that the gram-positive bacteria show a low resistant profile compared to gram-negative bacteria. Although the resistant profile is varied between years, some of the bacteria taking a high resistant profile during recent year and should be put in more focus. That's why we need to conduct more surveillance study in order to highlight any resistant mutant or any changing in the resistant profile, thus changing the drug of choice. This study has been published in a good journal called Infection and Drug Resistant with my research group. That's why I would like to thank all the research group for their effort. And then I would like to thank University of Hail for this funding, this research. And I would like to thank the recruited hospital, including Maternity Hospital in Hail. And also I would like to thank you for your listening. If you have any question, I will be happy to answer. Thank you. Thank you very much for your listening.
نشكر الدكتور عبد الرحمن بازيد. أيها الحضور الكريم، ننتقل معكم الآن إلى المحاضرة الرابعة لهذا اليوم بعنوان strengthening clinical laboratories workforce, improving quality and efficiency of health services, which will be delivered by Dr. Amna Abdullah Al-Ataibi. Please welcome Dr. Amna.
Assalamu alaikum wa rahmatullahi wa barakatuh. Hello again. For this session, I would like just talking about the quality control in general in the lab and how that will take us to the high qualified results and the lab diagnosis. This is the outline I'm going to discuss it today. I will take you step by step and to know the final sessions I will end with the knowing versus doing and how we're applying that in the reality life. I will start this is presentation usually by the cases, and after every cases I will discuss how that case take us by deep analysis if can we avoid it or not to avoid it. First of all, I would take that's the case one. I will give this title like right patient, wrong sample. The story started when there are a patient 72 the patients that in near urgent selection near surgery. And the surgery asked that patients to go to the lab and do the basic test, which is normal, basic CBC type, blood grouping type, and cross-matching. The pharmacy in the lab collect the sample, and the sample sent to the lab for the laboratory diagnosis and analysis. When the result come up to the doctor noticed something a little bit weird. There are large and surprising change in the hemoglobin value comparing with the previous samples. So the physician asked one of the team to go to the lab and investigation. Maybe the sample is mixed up with another one. When during to the lab investigation, they found the right information in the tube, matching the information in the quicks, matching the information in the data system, which will release the result outcome. So what's the problem? How that make the hemoglobin very high? The doctor sure and the patient is not in the treatment, which can change the hemoglobin between 1 week to another week. So they go to the lab specialist who do collecting the blood, and they ask them if they figure out or have any information that can help them. They answered that, I remember when the same time that patient to come to the room for collection of the blood sample, there are other old patient, both of them sharing the common name. Perhaps there's something happened and they're changing the tube this time when collection the sample. I remember the area is crowded and I enter both of the patients at the same time into the room for blood collection. When a deep investigation in the data, we found that the other patient are requesting for CBC because he is in hemoglobin treatment. Okay, hang on, and this is what is happening right now. It's simply easy step, easy mistake, but that can cost more than we think someone's life, patient's life. How that is happening? I will take you to these questions. That questions, I call them wisdom of medical technology. First questions of this one can have impact in clinical outcome. Ask yourself that question. Does laboratory tests change the way a clinician think about patient? Then, if so, does that change in thinking alter the way the clinician manage the patient? Then, if so, does that changing in patient management affect clinical outcome, mortality and morbidity? Back again to our cases. Just imagine when the doctor or physician or surgeon accept the result as it. Doesn't she see the hemoglobin level changing surprisingly? And accept the ABO grouping and the cross-matching. So and that patient go to the surgery, which have a blood group different, tissue matching different, and the other patient who are in treatment hemoglobin are not responding very well. What's happened? Both of them, their life will be changing. Some of them maybe die. Some of them will suffering from the complication. So that is the easy mistake happen in the first sign and collecting the sample can cause someone's life. That take me here to another case I will discuss to end up with my point. That case, I give these cases, all that's the case I'm talking about it is already published in journal and somewhere in this universities happen. That cases, She died 3 months later after deciding to forgo the further treatment. I will come with the end of that story. There are a patient, woman. He is 22-year-old female patient. One day, he received a call from the lab, asked him to the back again to the laboratory because his sample is lost. So we need to collect the sample another way. What's happened to that patient? Come to think about how they think. First will be anger, and then the health trust will be reduced, delay in diagnosis. That patient story, she is a leaf away from the center where they do the analysis and collecting the sample. So it takes the time to schedule again for another appointment and to go to the hospital. 3 months when they are repeat all the processing before the result is come up because she has a liver cancer and the before treatment is not responding very well. So the doctor would like to give him to the chemotherapy treatment, but first of all, depend on the lab result. So that patient is died before starting the treatment because there are some delay in the diagnosis in laboratory because the sample is lost. So put in your mind that sentence. Every tube is a patient, and every lost specimen is a lost opportunity to provide the best care for our patient deserve. Mistake in laboratory, what cost us? Cost us time, energy, money, and also patient outcome. We can avoid all that one if we improve the quality and the workplace by managing control in the lab, following that protocol and analysis that system to find the high qualified analysis and test release. There are things I would like to highlight it here. Between the accuracy of the test and the benefit of the patient, black box called How Do the Doctors Turn Data into Decisions. If you see here in the lab, anything happen in the lab and send it to the doctor, that play a major role in the patient safety. What you are writing in the report for analysis, that can translate it by the doctor to following the treatment or taking the decision. So that's the reasons why I am here today and having chosen that topic, strengthening clinical laboratory workforce, improving the quality and efficiency of health services. Why the quality management is health in laboratory? Because 70 to 90% of the today medical decisions, diagnosis, follow-up, and treatment depend on laboratory test result, showing the important role of the clinical laboratory in the healthcare system. In addition, our vision Saudi 2030 is to have a dynamic society, well-being, well-health, and high healthcare system that we are all working in transformation in the health sector to improve the quality for the services that are providing and saving the patient's life. So that's the sector that we're working on it. We work on improving the value of health services, strengthen the benefit against the health threat. So when improving the quality control in the lab, I can sharing and participate in these visions to improve the services and provide the best analysis outputs in laboratory to write to the diagnosis which help the patient safety and life. So that's take me to the story for the lab, what's happened. Total testing processing, usually the story starting from patient, collection the sample, and then enter to what we call them pre-analytic phases. Pre-analytic phases mean anything that's happened before the sample reaches to the lab. Analytic, all things happen inside the lab for analysis the sample, it takes this phase. Post-analytic, that's all the phases occurring after the analysis and result release. Any mistake in that step can potentially affect the patient's safety and life. Based on the study published, the most common types of the error in medicine, laboratory medicine and their services, they found that about 46 to 68% the mistake was in pre-analytic phase. So the most common that it published in when the analysis, the management system in the lab, they find it in pre-analytic phases. Incorrect analysis order. What I mean correct analysis order? Sometimes the physician may be ordering the cyst or sample, The physician is ordering text for requesting to doing that examination, and you see the clinical history for the patient as a laboratory specialist or consultant, and see the test that is ordering by physician is not matching by diagnosis. So that's what cannot help the doctor. So it's not a right diagnosis or the right test. So in these cases, what we have to do? Do I keep silent? Do I do the test just and move on? If I take this side, I will lose reagent, lost time and money, and cannot benefit the patient. But what if I have a call and talk a clear conversation with the physician? I note that you request this test for that patient. However, I assume that test will not reach to the final diagnosis that can help you. Conversation easy between the physician maybe can choose the best and the right test for that one, so we can prevent that error from the happen. Other mistaken, can we see it or so? Incorrect test requesting, test request lost, patient identification error, patient preparation error, mislabeling of the test tube, sample collection error, incorrect handling of the sample in case of transportation. So that is the most common in this phase. Based on analytic phases, the mistake that occur between 7 to 13%, usually in sample lost, sample mix-up, or equipment failure, or analytic error. Post-analytic is higher than analytic. It's about 19 to 37%. So it's totally in total test result lost, turnout time, transcription error, and incorrect interpretations. Sometimes, as we high qualified, we have visions into behalf of a high qualified lab, so it should be the sample or result release on the time, saving the time. Lost the requesting or the analysis or the report, not entering the data on the time. That is delay. That delays can affect someone's life when the surgeon or physician need that result. Cases, for example, in emergency. So that's the most common and based on that phases in post-analytic. What I mean by quality in medical lab. Quality in medical lab is talking about, it's referred to all dose processing and procedure design to ensure that results of laboratory analysis are consistent, comparable, accurate within the specific limit of precision. So it's accurate and precision at the same time at high quality and interpretation. Some of other, it just give him an easy definition, meaning achieving positive patient outcome through control the pre-analytic, analytic, and post-analytic error. So avoiding error, the quality of the test result analysis is very high. How to avoid the error in the lab? By following the control or quality management in the lab. I sure every lab have a quality manager, a quality control system, who can control the result of the test. Even that in the machine, auto machine, calibration, work on it, following the instructions, all that can help to improve the quality in the lab. When compared how the people or researchers in the last year or past year looking to the lab to the modern medicine looking in the patient by this concept towards a patient-centered approach to the laboratory actuated. In the past, usually we looking to the lab error or something related to the laboratory by this way. Test implemented in one of the pre-analytic, test performance analytic, and test release and return to physician with post-analytic. That's it. That we usually inside the wall of laboratory, not go outside there or there. However, for modern medicine, that's all this picture we see here is to approve for toward the patient centering, starting from testing ordering until the clinical economic outcome is happening. Analysis, that's one, can easily detect where the error is happening. As I said before, simple chat with the doctor can help. Sometimes when have a result, a high result, for example, abnormal result, something that weird when you interpretation result, you can talk to the doctor to understanding why that is weird for you. Simple discussion can help you to arrive to the right diagnosis. Looking to the laboratory diagnosis from ordering testing result and to the release of the result, is like puzzles. If the puzzles is perfectly fit to each other, this will give you the whole picture, which caring the patient and maximize our health service presented to the patient and then to the public health, to the community, and improve the health system. So when I look into the lab working from the ordering of the test and to the result released to the patient and the back cycle, that's helped me to maximize the accuracy of the lab work. For example, sometimes we are not the one who collecting the sample, sometimes collecting by the nurse. So make sure the sample is correct by the right way and the right positions can help you to reach the right diagnosis. That is the type of the communication inside the healthcare system to provide the much better result and maximize minimize the medical error in the lab. That's make the similar picture that I highlighted in the previous lectures, the whole story from the starting. Anything happened between that step, we call them in the lab quality failure. What I mean by quality failure? Something in the system of that lab, failure in the quality control system, and the managing control system in that lab is not going very well. So we need to stop, analyze, know where is the error, and how to avoid that error in the future. As I mentioned before, clarity is a key for effective communication. When you state everything in very clear way, testing the order, the test in the clear way, interpretation the result in clear way, no confusing. In the lab work, inside the lab work, writing a protocol, writing the information, the instruction in the right way, which prevent any confusion. For example, if I am the one who is responsible to the work in the machine from the morning shift, I have to lift the note for anything for the one who comes to a later shift. If I am during the working work, find something is not usual, I have to write it and document it. Why I need to document it that? Because retain that if it's repeated condition or repeated situation, that's mean I have to stop here and do something to manage it. Finally, I want this. There are a series of slides is coming, like a story. It's talking about knowing versus doing. All of us, we know the information. The hardest part, how to apply that information in reality. So do your knowledge matching your doing? Easy thing. Lab safety. All of us, we know what is the lab safety and lab hazard. However, when they come to reality lab, none of us, or much of us, can following that protocol perfectly. Sometimes something between is happening when you are in routine lab and doing that every day, so it just something missing while you're not doing very well. There are three, when talking about unconscious and conscious mind, that remind me in the lab work routine. For example, if I am a manager of that lab and I assign that person to the work on this machine for all the time for calibration, for example, for 1 year, 2 years, 3 years, it's good because he will have a knowledge, have a good experience. However, if that affect that person, how that affect the person? Usually human being, when they're doing the work by daily basis, we come, first time when doing the consequence, awarenesses. So you are aware for every step you are doing. For period of the time, repetition will come to the unconscious brain. So we do it as a routine way. When do it as a routine way, I sure some of one here, do I do this? Do I put this reagent? Do I try that one? That's why, because you are working unconsciously, because something come routine. So it's much better how to avoid that mistake in lab, what we call them routine lab shifting. But before that, there are saying from ancient times say, no problem can be solved from the same level of consciousness that created. What that means? If I working the same thing every day, and I will do the mistake every day, but I can notice. I cannot notice that because that's something I do it every day. But someone else can notice that mistake. Easy thing, if you're writing something, piece of the paper, and leave it for a period of the time, 3 days and return back to that writing, I'm sure you will find something to correct it. That's what I mean when your brain consciousness and unconsciousness work together. So to avoid that mistake in lab, it's much better to make routine changing. So I make routine change between the time and the time. So every time the brain is reminded themselves to work again and again and again. And that is like a training for a brain that's helped to improve the quality in the lab. Second series for knowing and doing I would like to talk is accuracy and precision. Everyone I sure know that what's the meaning of accuracy and precision. Accuracy, it's when I call close measurement to the actual true value. Precision is the close measurement to each other. That's an example. We ask for lab technician to do a pipetting. We give them 100 pipetting and ask them to take 30 microliter from that dispense. See, pipetting number 1, the target is 30. If you see 30 and around 30 is not much higher, we can say that is accurate. Why accurate? Because the number is around the 30, not much higher or much lower. And besides, we can see pipetting for all the samples is similar to each other. Go to the lab technician number 2, pipetting accurate but not precise. Accurate gives me around the 30, however not precise, 33, 39, 30, 26. That's how can affect in the result. Pipetting number 3, we can see non-precise, non-accuracy. Why? All of them not in the true value. The technician number 4, accurate but not precise. We can not accurate, sorry, but precise. So that is very high jumping value between one to another. That's what in the lab easy thing we can miss it, calibration pipetting. When not calibration pipetting or doing pipetting in very right way, especially in serology lab, that will affect the result. Amount of, if you remember from the morning sessions, I said about a Breuil zone and boost zone and equivalent zone for serology. So if you are taking antigen higher than expected or antibody high expected in the serum patients, that will not give the right result and can affect the accuracy of your result. This, as I mentioned before, is easy thing, for example, of knowing but not doing, if that's one, hazards. How the hazards can affect quality of health and safety and productivity. Laboratory technician, specialist, consultant, anyone, we are like what we call them silent hero who save lives. So if you are missing to protect themselves from contamination inside the lab, they will spread contamination, harm himself and other relatives around him. So saving your life, increase the productivity and the quality of the health in public and save people. That is the easy thing in the lab, you can do it. Keep your lab organized. If you keep your lab organized, you avoid a contamination, you fight confusing, maximize the quality of your lab and your work in the lab. This is an interesting case that has happened. One patient, 83-year-old patient, admitted to hospital for fever, weight loss, and cough being investigated for possible tumor. Sputum was reported to be a positive for tuberculosis, but later review found false positive culture due to laboratory contamination. Further investigation found 14 additional patients with falsely positive TB culture. What's happened in that lab? One diagnosis TB positive, but he is not TB positive. More than 20 patients before diagnosis with tuberculosis positive. So what is happening to physician when they see the lab result is starting doing antibiotic treatment. So there are complications of the treatment. Patient take the treatment, but however they not need that treatment because contamination in lab. I can avoid contamination in lab and save the life. So that's what's happened. Delay in correct diagnosis, unnecessary treatment to the patients, treatment complications, pattern of other contamination discovered in that lab, a problem. After that lab is happened, that problem investigate where they found 200 patients diagnosed with the TB. So I have to call all that patient to repeat the result to confirm who is positive and who is negative and what happened to that patient. Revision laboratory procedure indicating the problem. If I every day in morning do the revision, do the quality control managed for me, I will avoid that mistake. Sometimes as a laboratory technicians, when I collection the sample, put your mind or interpretation the result, some other factor around you can affect the result. Example, some exercise can increase the creatine kinase and CRP. Medical history is good to know, to understanding when you do result. Some hormone will affect your result. Some drug affect liver enzyme and dehydration. So put your mind that when you do interpretation, you can ask the patient for medical history or in treatment. Hemolysis sample is not accepted in serology. Tourniquet, easy thing, but if the tourniquet is left in the patient more than minutes, that will affect the lab result. So I recommended anyone who's working in the lab or collecting the sample, put like a note in the wall, write what's something to know, to remind themselves all the time by what to do and not to do. So I recommended by the end of the sessions, priority of the area can be improved in the lab medicine, accuracy of the patient and specimen identifications, effectiveness of laboratory data communications, communication of critical test results, sample acceptability and rejection criteria, appropriateness of the test request, avoiding manual transcription data. So if you work in the lab, work on these things to improve the quality in the lab medicine and to avoid error. In addition, keep everything calibrated, conduct routine maintenance, operate the operating range for correcting parameter. I highlighted here by yellow why, because time from the time, the parameter data is updated. So keep your eye to updated normal range between time to the time. Don't forget to write the normal range for request because the doctors know that. But however, sometimes from machine to the machine, the parameter is different. Detect shifting of the time, any change in the lab, consider human factors that is happening, perform major assessment analysis to your lab to understand it. At the end, I would like to highlight this very important. When you research in data, publication data for research, you will find most of research, therapeutic research, diagnosis research, prognosis, and etiology. However, research in the quality and improvement of the lab is still very low as a research evidence medicine base. So I recommended anyone interested in laboratory to do the research evidence-based for lab tests and improving quality to enrichment the data for research regarding this part of the laboratory. Thank you very much for listening. And that is the take-home message. Put in your mind how we are working to develop the Hector set and transformation for Vision 23. Do your best, give reliable information that can give right diagnosis to the patient. Library benefits, healthcare benefits, patient benefits. Laboratory network excellent, enhance patient safety and effectiveness. Very much, and if you have questions, please don't hesitate and ask. Thank you very much. Thank you very much.
شكرا جزيلا الدكتور آمنة العتيبي على هذا العرض الرائع. He is a board member, co-founder, and chief medical officer of Sajaya. We'll be talking about an inevitable partnership in medical laboratories toward the private sector, know-how, and operational transfer. Please welcome Dr. Yasser bin Mohammed Al-Atiq to deliver his speech. عفواً دكتور.
Assalamu alaikum wa rahmatullah. Good morning, everybody.
It will be a dramatic shift in the presentations, shifting from pure science to pure business. So allow me to talk about a very important, I think, point and experience that we have had over time. How's this working? Can you help me here? You can put show slide. Okay, so I will tell you next, then you go for the next, okay? So today let's talk generally about how is the current status of the laboratory as a business, and we will try to give a very high level view about how it look like. In addition to the market assessment today when it comes to the laboratory services from private sector perspective, public sector perspective, and where we think that the private sector should intervene. Because I do believe that we have a major problems in the healthcare system. And as the former Doctora Amna, she said, I think the same level of consciousness that made the problems cannot make the solution. So we have to look for the solution. Next, please. So we'll try to move fast. It is a prayer time. Do you think it will? No, you have to make it as a play the slides. If you go to view up there, go up, up, can you go up? Show slides. It's on the view, go to view. Tup, 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 tup. Full screen mode. Yep, there we go. So let me move. When it comes to the Vision 2030, I think it was really transformational. Some people, they didn't feel it because the only people who did felt the impact of the vision is who lived before the vision and after the vision in, let's call it administrative role or leadership roles. And he would really feel the difference between the impact of the vision on how we are managing the healthcare sector and how we should take the healthcare sector into different dimension. And this is quite very important. We did a massive analysis when it comes to the healthcare sector during my past time in the private sector participation. I was part of the team who we did establish and analyze the whole healthcare system. In summary, that the end result is that we are pushing for privatization. We don't think and we don't believe that the public sector may bear the responsibility of the healthcare sector in the coming time. So the partnerships with the private sector, I think it should be not only strategy, it should be a must, and it should be something we work on. Shift from public to private, this is coming. Increased level of the provision, in addition to increasing the demand. And multiple drivers are playing a role over here. If you see, for example, the Ministry of Health today has already published the HoldCo. And HoldCo, as you know, is part of the steps toward the privatization, in addition to the PSP. Increased level of provision, and with the Vision 2030, that we do believe that the PPP models, in addition to the support from the Ministry of Finance, support has been budgeted, so it is just a matter of time. So the question is, where are we out of that? How we should participate? In addition to the demand drivers, and everybody knows that everything is pushing today very hard toward a demand. Not only that, multiple challenges when it comes to the population number, when it comes to the aging, when it comes to the chronic diseases that it is growing on a daily basis. Those has to be faced with a very robust, quick solutions, and we have to work together to make it. So corporatization and the digitization is part of the upcoming transformation. So in summary, what we are really looking for is to support the corporatization when it comes to the future clusters. And where is the private sector, in addition to the partnerships of the public sector and the private sector together, to support the provision of the new healthcare. Not only this, the selective PPP programs also has to be supported with multiple really private sector capacity. And when we say private sector, by the way, is not just only one body. It's huge. It's multiple sectors when it comes to the payer system, when it comes to the provision system, when it comes to the manufacturing, when it comes to multiple areas, and also digitization. As you know, also the future model of care is really supporting 5 major elements when it comes to the urgent care, chronic condition, the planned care, and the woman and child, and the last phase. And on each one of them, each vertical, it has its own huge program that needs a big effort from the support of the private sector as well. Let's take this one when it comes to the private sector has been replaced the MOH in terms of share the patient over the last few years. And as you can see from 2016 down to 2020, those data are showing that private sector is growing over the time and start to shift some of the patients from here to there. And this is a very important really shifting when it comes to the impact of the transformation. As you know, guys, that we started the programs and studying the healthcare sector in 2016. And during 17 and 18, a lot of efforts here, but see the results, it just came out on 2020. And this kind of shift regarding the patient flow is growing and coming, but we don't have actually 2021 yet and 22, at least in my slide, in my study. But these kind of shift, that means the participation of the private sector is growing. Total inpatients by the sectors as well, as you can see, in 2016 as in compared to 2020. And that means private sector is growing over time. And this is a very important message to everybody here. That means also the insurance system has to grow with the demand of the patient flow, as you can see here. So when it comes to the CCHI, in addition to the insurance, and just the next slide, the insurance penetration, the Saudi population is almost, for the Saudis, are forming 17%, for the un-Saudis are forming 83% for the Saudi population. In addition to the insurance penetration here, according to the CCHI, the Saudis do not have the health insurance, whereas more than half of the expats do. Insurance penetration is expected to increase given the recently announced reforms and the pandemics. And these are the latest actually outcomes when it comes to see that almost like a 50-50, and the massive growing among the expat population and insured and non-insured in comparison. Okay. So for the Riyadh, total population is expected to grow over time to reach on 2025 like 9.5 million population. See here where is the distribution regarding the age grouping, that aging also in Riyadh is increasing over time, and this is one of the factors that we need really to focus on, that aging among Saudis is coming on the way as one of the challenges as well to the healthcare system. In male in comparison to the female, and as you know that also the female care is increasing and more demanding for the Riyadh population between Saudis and the non-Saudis. As you can see here, that the Saudis are the majority and the non-Saudis are growing as well. So that means the influence of the insurance system would maturate over time. I will pass this going to what are the elements of the healthcare system. I will stop here just to mention something, that when you look into the healthcare system, is always complex. And if you want the watch really to run carefully with the clockwise, not anti-clockwise, then you should fix it properly. And in addition to insurance system would be part, provision would be part, other payer system would be part, in addition to the regulatory would be part, and each one of them has to work in harmony. And that's why the healthcare system is really complex and need people really to be patient, working together in harmony as much as they can. This needs a lot of effort and a lot of collaboration, and also maturity in the understanding the role of each other. So we should not really stand and look into each other in silos. We cannot work in healthcare system in silos. Respecting the research, like the professor presentation this morning was very impressive. In addition to the private sector as well, and appreciation that one and see in the future how would that impact the human mankind. In addition to the government part, today in the morning, Professor, he was mentioning that we need the support from the public sector. Where is the public sector in this very important particular initiative that can be really changing dramatically the patient lifestyle? So part of the transformation moves that the Ministry of Health as a regulatory and also area of provision today would be minimized over time. So he will be much more of regulator. The providers, there will be multiple providers when it comes to the private sector, the new holding company, and multiple others. So the provision would increase, the private sector participation would increase, and this is part of the intention of the vision. In addition to the payer system is getting bigger and bigger nowadays, and you have witnessed also over the timeline that the private sector is growing. Last statistics, maybe some of you they were not aware on the previous slides, but it was in the 2020 the increase was more than 25% in the last few years. So this is a very important slide that I would take some time to mention. Now, when it comes to the partnership, it's like, I don't want to call it like a marriage, but it's somehow of that. There are some kind of risks around that partnership, and we need to identify and reallocate those risks. So, giving an example on the payment. So if the private and the public, or the private and the private as well, so there will be a private-private partnership, there will be a private-public partnership as well. So what are the risks that we need to share together to make this kind of relationship happening? One of the things that it's always the hassle when it comes to the payment. Who would take the risk of the CapEx? And who would take the risk of the OpEx? And who would take the risk of the insurance? So redistributing that one is very important. What does that mean? So now the government, for example, they want to open a new hospital, but they will have a lot of CapEx, a lot of capital they have to inject. So what is the role of the private sector? What is the role of the banking system? What is the role of the investors? So these kind of allocation of such kind of risk is very important to be designed carefully as well. And this is part of the PPP process. When it comes to the OpEx, who will operate? And I think for us as a private sector, we are so much willing to participate in this and to participate in this fully. We have no problem when we go to the OpEx side. And regarding the CapEx, I think we can share some of the risks. So having the feedback from the private sector to the public sector to maturate the model that the public may step in and the private sector having it as a win-win situation. And I think today, Dr. Amani, she said about the win-win. So we have to look into always the win-win solutions where we can really stand to each other. Why? Again, we have increased population, we have annual inflation, we have a lot of challenges in the healthcare system. Healthcare system is like a massive train, is going to a direction that we need really to control it. We need to participate all together to make a better outcome. Now, part of the risk is also demand. Demand when it comes to the sales versus marketing, how we can bring the patient, and part of it is the awareness, and this is very critical and very important. So, some of the things that today I was really surprised by the professor presentation in the morning when he talked about Alzheimer's disease and the massive effort that has been done on the scientific side, but people, they are not aware about those kind of efforts, that some kind of medications are coming on the way to make the solution for Alzheimer's disease. So how can we enhance and encourage and make the awareness for the patients to come to us, to our facilities, to do the scans, to do the needed investigations, to postpone the Alzheimer, and also to be part of the health system to improve such kinds of solutions. So I think part of the things that some of the risks in the healthcare sector, and we need a lot of spending money, by the way. Awareness is not cheap. Awareness is expensive. So we need to work together how we allocate the risk for the awareness, for the sales as well, and for the marketing elements. Okay, now for the supply, and I think for you in the laboratory, you have a lot of things regarding the supply, and you deal with it a lot. But part of the things that we need really to reallocate between the private and the public to make a successful partnership is the supply. How is it delayed? How is it the supply we can do it versus cost inflation? And this, what we mean by it is to have a specialized transportation system and the supplying system. It is very expensive quality measures we are using in the healthcare sector, unlike other sectors when it comes to the quality, and that we need to work it on mutually. For the technology, one of the major actually challenges for the technology is that it is going rapidly and maturating rapidly and changing rapidly as well. So these are one of the challenges that both sectors has to work hardly what kind of technology we need to adopt and when to the healthcare system to be done rightly. Okay, regarding the inflation, for the economy in general, it is inflating by 2.5 to 3.1% annually. This is for the overall economy. But when it comes to the healthcare sector, it is the inflation of the healthcare is almost like 7.5%. And this is one of the challenges that everybody in this room should really give a high attention. Healthcare is inflating annually more than the economy inflation. التضخم العام في الاقتصاد أقل بكثير من التضخم السنوي الموجود في القطاع الصحي. And this is really huge. We need to look at it very carefully. That means because we are elevating the quality, because we have new technology, because we have a lot of demand, because we have expensive medications and pharmaceuticals are killing us. So these kind of things are really injecting much more inflation in the healthcare sector. And I think this small line, هذا الخط البسيط, it is a very big gorilla is coming on the way. And we start to feel it every now and then. Also regarding the cost, direct versus others, versus the indirect, and actually this is very important because one of the major risks is increasing the cost of the healthcare, and that's related to inflation, related to technology, related to supply complexity, and related to also increasing the demand. So the message here is we have to work hand in hand, private and public, very carefully to go through this kind of major challenges. I do want to consume more time, but I will try to run fast. This is a deep analysis regarding the Kingdom of Saudi Arabia laboratory system, and operation as well. One of the challenges that we found is that the IT system, not the implementation of the laboratory information system, more than 43% of the laboratory in the KSA, they do not have a functional laboratory information system. And this, when we talk about this number, usually it is public and private as well. So this is huge, this is major. So means a lot of information can have a human error in addition to access to data, which is a major fundamental issue. It's not achievable in this way. The challenge of the transportation. I think the challenge of transportation has different elements when it comes to the quality of the transportation, when it comes to the timing, when it comes to the impact on the TAT, in addition to multiple other factors from the qualification perspective. We have major challenges in those three. So after we have done a major analysis over the country, in summary, IT system, we need to work on it, transportation as well, and the TAT regarding the results need to be looked at. This is also a further deeper analysis for the laboratory expenditure on annual basis. For the workforces, as you can see, they are forming more than 65% of the spending. Okay? So when you say, okay, we have a very expensive machine in the laboratory services, actually your problem is not the machine. Your problem is the know-how, is the expertise, is the workforce. This is from expenditure perspective. When it comes to the maintenance as well, it is the third one. So reagents are just forming, almost like here, maybe 33% out of overall. So that means we need to review this one, either by automation. So you will say, okay, we need to make layoffs. No, maybe redistribution to different specialty. So not always when we cut down the workforces, that means evil. No, it means redesigning your system into an areas that we need people to be more expertise and that we need. So if I ask some of you now, we know everybody is going to artificial intelligence and different systems. How many AI expertise you know around you? Few, one, two, none? And we know that it is booming. So that's why redesigning the workforce is critical. Come and see here for the laboratory workforces, the technicians versus the consultants who are the physicians, in addition to the physicians in general, specialist technician as well. These are the numbers so far by the Ministry of Health. Okay. Moving toward this one, the majority of the tests are undertaken in the Ministry of Health and general hospitals. The general move toward the privatization should therefore have a positive impact on the private sector investment as well. So if you see here, for the general hospitals, they are forming the majority in millions. For the regional labs, this is in millions as well. And these are for the MOH specialist hospitals, and these are for the private sector. So in total, within Riyadh and Jeddah, approximately 45 million volume of tests were conducted by the Ministry of Health. Now, what is the rule in the Riyadh region between the MOH and between the private? So you see the private in light blue, and you will see the MOH in dark blue. So number of laboratory test sector between 17 and 25 in millions, and these are the predicted or forecasted numbers. As you can see, still the private sector is less than the Ministry of Health. And these are the distribution regarding the types between the biochemistry, bacteriology, blood, and lab, and these would impact as well how you design your investment here. But the message from this one is to compare it with other regions. So if you see, maybe I didn't put it here in my presentation, but if you see Jeddah is having a very good share with the Ministry of Health. They are almost comparable in the Ministry of Health, but then that because in Jeddah, the private sector is much more mature. If you see, the clinical laboratory market will increase by 231 million lab tests in 24, and the majority of which is done by the Ministry of Health. And this represents an opportunity for the private sector in general and how we move forward. So if you see this is the private supply, and this is the MOH supply, and this is how does it grow. With the push that we have witnessed in the earlier slides, that people are really pushed now through the insurance system, through the provision to the private sector, that means the partnership between the two sectors is something we have to do. So now two questions. Why partnerships are inevitable? ليش الشراكات حتمية لنا جميعا? And how? So, why? See those bubbles. I love it and I hate this slide, but it shows the impact and the problem. Look here. The economy is growing as an inflation by 3.1%, while the healthcare is forming 7.3%. See the diagnostics, which is radiology and laboratory. The inflation among diagnostics is 13.4%. This is for the global measures. And that means we have much more challenges on the diagnostics. I'm a radiologist by background, so when we say diagnostics means radiology and lab. So the radiology and lab is inflating annually with this number. That means the cost of the diagnostics would be almost like within 5 years is more than double. And this is quite big from cost perspective. And I think everybody witnessed that. So there is something to sacrifice. To reduce the cost, what we do, you in labs, we in radiology, what we do to sacrifice this inflation. Usually we said, okay, I don't need this kind of technology, this is very expensive. So when I buy a new machine, I start to cut out of those technologies. So what I'm cutting, that means I'm cutting a lot of know-how. So I'm not learning the new technology. I'm avoiding to learn new technology because of the cost. I'm avoiding to grow in knowledge and practice because of the cost. And this is also another controversial side. I'm passing the time. عدينا الوقت. طيب. باقي لي شريحة واحدة بروف إذا تسمح لي. طيب. Population is aging. 4.5% year to year. Insurance burden is increasing by 10% annually. Population increase as well. The know-how cost on the manpower, and by the way, the manpower shortage in the healthcare sector is more than 30%. When it comes to the advanced technology, it's almost like 5 times on annual basis. So how we should do it? And I think we should have some kind of a new mindset that we should partner always between the public sector and the private sector, forming new companies to do the services. And this is the summary of it. There are some details, but I think the time is not helping us. But this kind of partnership, and this is a very important slide, this kind of partnership can be in form of ACOs, can be in a form of PSPs, accountable care organizations, can be in a form of private sector participation, can be in a form of PPP, public-private partnership contracts, can be in a form of joint ventures, can be as a consortiums, اللي هو عقد صداقات وتحالفات مع شركات, or can be in form of MPOs to pass the challenge. Going back to the same slide, one of the things regarding the challenges is the payment. And I put it as a standalone slide to mention that the types of payments that you are using today في اللاب عندكم مشهور ال GPPRR, and I think you have done a very good work in that dimension. But this is one of multiple ways that we can have a very successful partnership. Thank you so much for your time. طولنا عليكم. ما في مجال للأسئلة، صحيح؟
شكرا جزيلا دكتور ياسر على هذا العرض. أيها الحضور الكريم، نأتي وإياكم إلى آخر عرض لهذا اليوم لهذا السيشن بعنوان Impact of interaction between drugs and laboratory test results, which will be delivered by Dr. Ubaid Shaifani, a board member, co-founder, and chief medical officer of Sajaya. Please welcome Dr. Ubaid Shaifani.
اختصر. السلام عليكم. السلام عليكم ورحمة الله وبركاته. Good afternoon, everyone. So, usually most common factors of diagnostic error are unexpected. So, unexpected factors that lead to misdiagnosis. One of the most important factors drug laboratory test interaction. So what's the drug lab test interaction? Those interaction which affect the result of normal lab report due to presence of one or more drug that can be cause of interference. So this false positive or false negative can be outcome. Clinical laboratory practice represent constitutional of clinical decision making. About 60% of the medical decision at early level of the healthcare. Result of laboratory tests have key role in establishment of adequate diagnosis as well as in the evaluation of treatment progress and outcome. But with hundreds of laboratory tests and thousands of medication, there are many drugs lab interaction that can occur. The number of medication effect laboratory tests continue to increase. The new pharmacological agent and introduce a laboratory test methodology change. About 40% of patients have laboratory tests influenced by drugs according to a study. It was in 2022. So ask about what the many factors can affect the lab test, such as diet and the male and the gender and the age of the patient. So doctors and clinical pharmacy usually aware of the main therapeutic effect of a drug, but other change in biochemical parameter often unexpected because they be unrelated. The main action of a drug lead to incorrect management of the patient. So this mechanism of a drug interfere in the laboratory can be classified to biologic, that means direct action of a drug, or it is metabolized inside the body. For example, furosemide, spironolactone from the group thiazide, or diuretic. Another one, analytical or methodological interference with method of testing. That means color, mass of lab test, and chemical pathology have colorimetric or photometric component which can be interfered by virgin chromogenes, creatinine measurement, and color change of urine. For example, rifampicin or ferrous sulfate. Ascorbic acid or vitamin C. This common source of interaction in the statement of glucose, hemoglobin, and nitrate in urine. Ascorbic acid supplement can interfere with reagent used. Therefore, patients should avoid of high dose of ascorbic acid for 24 hours before urine collective rotation examination. So what's the pharmacological effect interference? Thiazide and lab diuretic, such as spironolactone, such as Lasix or furosemide, cause increase in renal excretion of potassium, creation of potassium. So we will have decreased serum potassium level in the patient. Increased blood urea nitrogen can occur a result of excessive fluid loss during treatment with thiazide and lobe diuretic. Another one, toxicological. When drugs damage a certain organ system, abnormal lab test will be one of the first signs of the problem. Isoniazid and rifampin or rifampicin produce hepatotoxicity. Elevated hepatic transaminase will be sign of liver inflammation. Prolonged course of high dose aminoglycosides such as gentamicin, amikacin, this antibiotic cause acute renal failure. So, inaccurate lab result led to unnecessary testing, misdiagnosis, and a lot of worry for the patient, additional cost, and increased morbidity and mortality by patient exposure to X-ray or CT scan or MRI. So this most common class of medication interfere with laboratory result. Antibiotics is most common, such as the amoxicillin, ampicillin, this direct composed penicillin. Also the trimoxazole, daptomycin, erythromycin can cause falsely elevated result in the prothrombin time and in the NR. Doxycycline also can cause false elevated result in the catechismin test. Levofloxacin also and rifampin can cause false positive in the urine drug screening for the patient obtained. Ciprofloxacin can elevate result in urine protein test. So contrast media affect protein level in the blood, which can manifest as falsely increased result in the protein blood test or protein urine test. Gadolinium contrast agent can false decrease the result in chloromictral or photomictral for serum ACE inhibitor and calcium and zinc. Also can cause positive interference in the creatinine, magnesium, and selenium, and total iron binding capacity both positive. After contrast media are administered, patients should wait at least 4 hours before having lab collect. Proton pump inhibitors such as omeprazole and esomeprazole, bentoprazole can cause and the stool antigen test false negative in the urea breath test. With long-term use, proton pump inhibitor can lead to false positive in the urine breath test and increase INR. So psychotropic medication such as antidepressant, antipsychotic, and antidyskinesia agent can cause false positive on drug screen and pregnancy test. Hormones such as steroid and birth control can affect lab result as well. ASR is elevated by oral contraceptive, vitamin A, and by methyl dopa is decreased by corticosteroid, methotrexate, and by NSAID. Pregnancy test false positive by phenothiazine and methadone. Bilirubin increased by acetaminophen, barbiturates, erythromycin, diuretic lobe or thiazide. Decreased by corticosteroid, vitamin C, phenytoin, and levodopa. Also cholesterol increased by beta blocker, anabolic steroid, diuretic, and oral contraceptive. Decreased by alpha blocker, ACE inhibitor, and calcium channel blocker. So finally, how can we avoid this interaction and at least low interaction? First, be worried because the FDA doesn't require drug lab test interaction during new develop medication. The absence of a drug lab test interaction in the prescribing information doesn't preclude the existence of it in related interaction. In the case of offer the counter and herbal medicine, even known interaction, may not appear on the package labeling. Complete list of medication the patient is receiving or has recently received is essential. Second, the fourth result that don't correspond with the clinical picture, clinical and laboratory staff should obtain a confirmatory test by an alternate assay method if available. Finally, investigation into many of the known drug lab test interaction are a result of the case report, publication of confirmed or suspected drug lab test interaction can improve this understood fast of the healthcare reporting interaction to the Saudi FDA. Thank you so much for listening. Thank you. Any question? Where the doctor? دكتورة طاهرة؟
شكرا دكتور عبيد. السيدات والسادة الحضور الكريم، من لا يشكر الناس لا يشكر الله. في ختام سجن 1 لهذا اليوم يسعدنا تكريم المتحدثين تعبيرا عن امتناننا لهم لتلبية دعوتنا ولما قدموه لنا من معلومات قيمة. لكم منا جزيل الشكر. يتفضل الدكتور عبد العزيز الكثيري والدكتور شادي الشوير لتكريم المتحدثين. نبدأ بسعادة البروفيسور رائد البرادعي، فليتفضل مشكورا. الدكتورة آمنة عبد الله العتيبي. الدكتور عبد الرحمن بازيد. الدكتور ياسر العتيق. في أحد بيستلمها عنه؟ طيب. الدكتور عبيد الشعيفاني. أيها الحضور الكريم، إلى هنا نكون قد أنهينا محاضرات سجن 1 لهذا اليوم. أيوة، في شخص كمان بيتكرم. اوكي، الاستاذ فلاج بداي الحربي.
اخوي مظبط واقول لك كذا مع
من الدنيا ما اعرف. عجزت انطق. اي أيها الحضور الكريم، إلى هنا نكون قد أنهينا محاضرات سيشن 1 لهذا اليوم. شكرا لحسن استماعكم. ناخذ بريك لمدة نصف ساعة وبعدها نعود لمحاضرات سيشن 2. شكرا لكم. الحضور الكريم، في حاليا وركشوب لدكتور ستيفن، طبعا اختياري، اللي بيحضر هو فري للجميع. حياكم الله جميعا. هذا المفروض شوي هنا تروحي على هذه الجهة، هنا باك. ايوه، وهذا البوينتر. شوفي البوينتر يشتغل.
Sorry? Yeah, sure. Just please inform me when should I start. Hello. Nice to meet you. Nice to meet you. Are you gonna have a lecture now? It's actually up to you. I'm ready to start. So.
No, because we're gonna have based on the schedule. Okay, we have a session about defeating TV. It will start 1 o'clock. So what time did they give you?
It is totally up to you. I can start right now. My presentation will take around 20 minutes, not more. So I can start right now, or we can start later. So you're the boss here.
I'm the moderator for the next session.
Okay.
So
So maybe it's better to start right now? Okay. So can I?
you can start.
Okay, great. Thank you so much. Okay. Assalamu alaikum, dear colleagues. Let me introduce myself. My name is Stefan. I'm working in the company called Tikan. Maybe you heard about this company. It's a Swiss-based company that is developing solution for modern laboratories for the automation on these laboratories. So just a few words about the company itself. We're based in Switzerland. We have a history of more than 40 years. We're involved in a lot of development processes for the new technologies that are widely used in laboratory market all over the world. Actually, this is clinical hospitals, it's pharma companies, it's scientific laboratories, a lot of them. Our headquarters are located in Männedorf city in Switzerland. Nowadays we have 3,500 employees around that. And actually we're one of the largest companies. Oh, is it for me? Check, check. Oh, yeah, now it's better. Thank you. Yeah, so today I'm going to tell you some things about our approach to automation and about our new products that can be quite exciting for you. So let's start with the structure of our company. Just a few words. Actually, we're divided in two parts. The first part of our company is focused on all and, on all, yeah? Yeah, sure, yeah. Sorry for that. The life science business part of our company is focused on all end user activities, and we are designing, constructing and manufacturing products for scaling different laboratory workflows, and we will talk about the workflows a bit later. The other part of our company is called partnering business. We're developing spare parts and special models that can be used in different instruments that are actually by fact manufactured by different other companies.
You know how?
Sorry? Working. Is it? Oh, yeah, now it's working. Yeah. Technical issue. Part focused on managing of the spare models be used in different. Something like that. Is it working? No. Check. No. Not working. I don't know why. Check.
The mic is good. It's louder without microphone.
So, partnering business is about our spare parts and models for. Sorry? Oh, yeah, now it's working, yeah. So sorry again for these technical issues. Let's jump to the next slide. Actually, what is the concept of our company? What is our approach to the market? We're scaling different laboratory workflows. And actually, our company is mostly well known for the automation of different types and different applications in sample preparation. Of course, a lot of things that you can do in the laboratory, you can do it by your hands. But it is not always good, because all of us, we're humans, we're making some mistakes, especially when we're working with some complicated, sophisticated protocols, and also, of course, when we're working with very large batches of samples. Very good example of the start of automation era has appeared when the COVID times, those crazy times happened some years ago. A lot of laboratories were facing a lot of samples for PCR testing, for ELISA testing, for other types of testing, and these workflows, it wasn't possible for humans working in the labs to their manual workflows and make them automated. Also, we have a special solutions that I will talk about a bit later that we use for the final part of every laboratory workflow. It is called detection or analysis. For example, we have different multi-mode readers, we have even microscopes, we have cell counters and cell analyzing systems that can be also used in some of the labs. But as a whole, we call it like laboratory automation. So, some words about our solutions, about our products, about our instruments. So we are mostly well known for our solutions for liquid handling. Such platforms like Fluent or Freedom Evo, they can perform liquid handling, I can say, for more than 90% of the standard laboratory workflows in different applications all around the world. Also, for those laboratories who are facing the very small volume liquid handling, starting from picoliters, we have a special units that are called digital dispensers that can be used. For example, in modern genetic laboratories, especially laboratories that are working with NGS, also mass spectrometer laboratories, of course, these instruments are used. And quite a new instrument that I will also show to you is a single cell dispenser, because nowadays a lot of technologies are based on single cell screening. It can be mass spectrometry, it can be sequencing, it can be different type of cell profiling. We now have a special instrument that can cover these tasks. Also, we're proud to have special solutions for LC-MS sample preparation. Generally speaking, it's the processes of automation of solid phase extraction, but also we can automate different applications that are based on liquid-liquid extraction and different other protocols that are widely used in mass spectrometry chromatography labs. Also, we have products that we call our detection portfolio. It's microplate readers and washers. They are mostly used in cell laboratories and the laboratories that are working with ELISA protocols. Of course, we manufacture some consumables that can be used like a standalone solutions, but also they can be used in our instruments. These are disposable tips that are used for liquid handler. These are different types of labware, for example, for cell counting, and also, of course, solid phase extraction cartridges that are widely used in mass spectrometry market. And also, the thing that we're really proud of, we have reagents for NGS library preparation and also for ELISA, especially for ELISA automation or semi-automation. It depends on how the laboratory is working. Also, our products, they always can be connected to IT environment of the laboratory. So you can always adjust your instrument, adjust the workflow, adjust some settings using our special software solutions that are called CNS, Common Identification System, and Introspect. With the usage of this software, you can even distantly control your instruments and understand what is happening in your lab, even when you are staying outside this lab. And the very important thing here that actually this software can be easily connected to different types of LIMS system or data management systems in the world. We're totally open for that connection, for that integration. So in case your laboratory is using any kind of laboratory information system and you want to track your sample, you want to perform the modern type of sample management, of course we will be connected there. So let me generally speak about the main applications that we're covering with our automation systems. Of course, it's molecular genomic methods. There are different kinds of them. Of course, it is extraction of nucleic acids. We can automate different workflows using any type of reagents from any type of manufacturers that are available in the world. We are not manufacturing, for example, reagents for nucleic acid extraction, but our systems are open to work with any solution. For example, it can be magnetic bead-based solutions, it can be column or vacuum-based solution, anything is possible. Of course, our instruments are widely used in PCR laboratories. So, for example, if you want to set up your PCR and even have your thermocycler integrated in the robotic station in case you're facing a lot of samples, it is possible. And also, the very important thing, the sequencing NGS workflows. Nowadays, a lot of laboratories are working with them. We hear about NGS every day from mass media, and we have special solutions, special configurations of our platforms that can be used for library preparations and all the associated methods for the modern types of sequencing, including single-cell sequencing. The second part that we can automate is, of course, immunological methods. There are different of them, but generally speaking, we can automate the whole ELISA workflows from native sample to the final result. We can automate the workflows that are based on multiplex assays. For example, it can be Bioplex or Luminex. I hope some of you have faced solutions. And also, these methods are a bit outdated, but still some laboratories, especially veterinary laboratories, are using them. Different types of agglutination assays. We also have solutions here, and we are proud to share the information with you. For the chemical analytics market, we have special solutions for the sample preparation for chromatography and mass spectrometry, as I've said, including liquid-liquid extraction and solid phase extraction. And even we have specialized models and specialized solutions for nuclear magnetic resonance sample preparation. That is quite a sophisticated thing, but we can do it in a fully automated way. And of course, our platforms are widely used in cell technologies laboratories. So, for example, we can automate working with cell cultures, with stem cells. We can automate cell culture maintenance. We can automate working with Petri dish. We can automate working with different types of microbiology cartridges that are used in different types of microbiology screening systems. So that's we have. Also, in case it's necessary to perform any kind of cell selection or cell isolation, we have special configurations that can help you with it. So, for example, the classic thing is a blood fractionation with buffy code extraction. When you want to extract, for example, nucleic acids only from a leukocyte fraction, our systems can do it for you in a fully automatic way. And in case you are working with any kind of biobanking or cryostorage, in case you have any kind of facilities like that, we have a special instruments that can help you to prepare your samples for the cryostorage, and also they can even manage the cryostorage facilities itself, because we have a special drivers that can drive and adjust the biobanking workflows from different manufacturers, because nowadays there are a lot of companies who are manufacturing those biobanking instruments, and we can drive them. So let me just show you. Oh, excuse me. Can I ask you to start the video, please? Sorry, can I ask you to start the video? Yeah, thank you for that. It's not working. Oh. I don't know why. Okay, so yeah, just without the video, I will show you how our instruments can be arranged. So, for example, this is a robotic platform that can be used for cell culture maintenance and preparation for biobanking. Just a few words. We have liquid handling models that can perform all the liquid handling operations in a fully automatic way. Oh, sorry. Yeah, in a fully automated way. We have multi-channel manipulators. For example, if you want to perform any kind of liquid handling in a multi-well format, then it wouldn't be a problem. Also, we have a robotic gripper manipulators that can be used to transfer different objects like microplates, single tubes. And we have a lot of integrated models here. So, for example, we have some special storage places for microplates and tubes. We have integrated balance for weighing the samples, and it is not clearly seen in this picture, but we also have a centrifuge integrated under the work table. So, for example, if you want to automate the process of centrifugation, it is absolutely possible. I'm sorry again that the video is not playing in the correct way, but yeah. Also, yeah. Excuse me, can I again ask you to start the video, please? If it's possible. Can you please start the video? No. Okay, so sorry for that. Let's just skip these slides. So also, we can work with microbiology workflows. So in case you want to perform any kind of automatic Petri dish plating or seeding biomaterial, or you want to perform the automated colony picking, we have special models for it. Also, we're proud to have the special solutions for ELISA automation. So actually, our instruments for full ELISA automation, they contain all the necessary models that are used in standard classic ELISA workflows. We can perform the liquid handling of native samples with the detection of liquid levels, with the detection of different types of mechanical impurities in those samples. We can automatically transfer those samples to the microplates that are used in ELISA workflows. And for microplate processing, we have all the necessary models inside the instrument. It is working totally without any manual intervention in totally automatic mode. So we have watchers, we have incubators, and we have readers. So in the end, you will get the final result of your assay or for your samples in electronic mode, and it can be again automatically transferred to the laboratory information system. Also, as I told you, we have different reagent kits. They can be used for ELISA automation. Please note that our systems that I was talking about in the previous slide, they're open to be used with any reagent kits. But if you want to choose our original solutions, of course, we would be happy to supply you with our original kits for ELISA. Also, the thing that we're really proud of, and I can easily say that we are driving the development of the modern laboratories in that way, it is automation for NGS library preparation and all the associated methods. So again, we can perform the manipulations with native samples, we can automatically perform the nucleic acid extraction, we can perform the automatic normalization of concentrations because it can be crucial for some certain types of NGS or HLA workflows. Of course, we can automatically prepare libraries for NGS. We can perform all the necessary quality control steps if you have them, and even we can be directly connected to the sequencing platforms from different manufacturers. I can easily say that these sequencing platforms can be from Illumina, from Thermo Scientific, from MGI, BGI company, from PacBio, from Oxford Nanopore, from 10x Genomics, and from Singular Genomics. It's not a problem. We have solutions for all of the possible applications. Yeah, and also, in case you're interested, we have a small, not big, but small, but very interesting portfolio of our original reagents for library preparation for NGS workflows. Currently, it is for Illumina-based workflows, but in the near future, we will have some more solutions. But again, in case any of you is interested, we would be happy to share additional information with you. So yeah, let me skip this slide because video is not working, but let me show that some of our platforms, they can be also used in the manufacturing processes. It maybe sounds a bit strange, but the main idea here is that actually our platforms, they can work, for example, in the laboratories or in the manufacturing sites that are manufacturing vaccines or different types of testing kits, for example, for PCR, for ELISA. For example, in this picture, you can see the platform that is used for the manufacturing process of PCR COVID testing kits. So here are two models. One is performing the liquid handling, the filling of those small vials, and the second model is performing the automated capping of these tubes. In some cases, it is very necessary to have some models, some devices integrated, and these devices can be manufactured by other companies. And actually, it's a unique benefit of Tican that we're totally open to be integrated with any kind of solutions, any kind of instruments from different other manufacturers. We're staying in a very, very friendly connection with them. And for example, if you have mass spectrometers, sequencing platforms, different types of cell analyzing systems, or even just thermo shakers or anything like that, we can integrate them right inside our platforms, and moreover, we would be able to control those instruments directly from the original software of our platform. That's quite impressive, I can say. Some words about our detection portfolio. We have different types of microplate readers. So the basic level of these readers is Sunrise and Infinite F50 readers. I believe that you have faced them because there are more than, I think, 60,000 of installations that we have all over the world. Usually they are used in standard ELISA workflows. Same for our washers, microplate washers, Hydrospeed and Hydroflex. They are used in most of the ELISA laboratories in the world. But in some cases, you have to perform the reading of not only absorbance, that is quite often used in ELISA, but also some other things, like, for example, fluorescence or luminescence or even polarization of fluorescence. It is possible with our readers that are called Infinite 200 and Spark. These readers are multimode readers. They can be equipped in ways to mostly meet the requirements and demands of your laboratory. Let me add that we have a very new instrument that is called Spark Cyto. This is actually a combination of multimode reader with a microscope inside and with a cytometer inside. So it can cover a lot of different protocols, and actually you can get some kind of pictures that you're usually getting with the microscopes. But here you need to use only a microplate reader with some additional options. And yeah, the thing that appeared in the market just about 5 or 6 weeks ago is a new system that is called Tikan Uno. It is used for single-cell dispensing. Again, in modern techniques, in modern laboratories, there are a lot of workflows that are based on single-cell analysis. Again, it can be sequencing, it can be spectrometry, it can be different types of proteomics assays. We can do it, and we have a special instrument that can perform that kind of single-cell dispensing and maintenance of single cells in a fully automated way, and we're really proud of it. So thank you. In case you have any questions, I'm happy to answer. Thank you. Okay, no questions? Okay, so thank you. Sorry again for...
تبغى نبدا ولا تبغى ننتظر شوي؟ ها؟ Ready, Doctor? Abdulwahab? Ready? Good afternoon, everyone. We're going to start the second session for today, and today our title will be Defeating TB. شو اسمه الجامعة؟ أنا مش كمان شو اسمه هو؟ مدير الجامعة. Assalamu alaikum wa rahmatullahi wa barakatuh. Before we're going to start our next session, we'd like to introduce Prof. Khalid al-Migran, Khalid bin Saad al-Migran, the previous president of the Jamiat al-Majma' University. So can you please, Prof. Khalid, come to the stage? يلا تفضل تفضل. طيب اوكي.
تتشرف جمعية الحساسات الطبية بتكريم معالي الدكتور خالد بن سعد المقرن ضيف الشرف للجمعية والمؤتمر. شغل الدكتور منصب مدير جامعة المجمع من عام 2009 إلى عام 2021. 12 عاما من الإنجازات المشرفة. تأسست جمعية الحساسات الطبية خلال فترة رئاسته لجامعة المجمع. سوف ينضم الدكتور عبد العزيز الكثيري والدكتور شادي الشويعر للمنصة لتكريم سعادة الدكتور خالد المقرن، فليتفضل مشكورا. الله يعطيك العافية.
ابدا ما مشكله. Sorry everyone for the delay of the starting our session. Our session today will talk about the defeating of TB, and our first speaker will be Dr. Abdul Wahab bin Jum'a. Dr. Abdul Wahab bin Jum'a is a PhD holder in infection and immunity, inflammation from the University of Lancaster in 2014, specialized in Mycobacterium tuberculosis physiology in lung, and he's now the president of the regional lab in Riyadh. تفضل دكتور. حاولت تصلها.
طيب، بسم الله الرحمن الرحيم، والصلاة والسلام على أشرف الأنبياء والمرسلين نبينا محمد وعلى آله وصحبه وسلم تسليما كثيرا إلى يوم الدين. First of all, I'd like to thank the organizers for this conference, and my presentation is a little bit technical and scientific. It's about two publications were introduced in 2021 and 2023. I will focus on tuberculosis research, and I will begin with a tuberculosis overview. As we all know that TB is the 13th leading cause of death and the second leading infectious killer after COVID-19 and above HIV. It has been estimated that worldwide 10.6 million new cases, and we have worldwide more than 1.6 million deaths because of tuberculosis. So what's the situation in Saudi Arabia? According to the WHO, this graph shows the tuberculosis confirmed cases from 2008 to 2021. We can see that in 2008 we have more than 4,000 cases, and then the trend is declined to reach about 2,800 cases confirmed in Saudi Arabia. The other chart shows the big problem of tuberculosis. The main problem of TB is not the number of cases. The problem of TB is the multi-drug resistant tuberculosis. And for the people who are not specializing in TB, the multi-drug resistant TB means when the bacterium becomes resistant to isoniazid and rifampicin, the most effective drugs in the first line. So, alhamdulillah, in Saudi Arabia, we don't have that much cases. Oh, sorry. We have in 2021 around 13 cases of MDR-TB. So the question that can be arise, what is extrapulmonary tuberculosis? We have two forms of TB infection. We have pulmonary, with the tubercle bacilli targeting the lung, and we have extrapulmonary tuberculosis when the TB bacilli targeting any organ other than the lung. extrapulmonary TB represented 16% of the 7.5 million incident cases that were notified in 2020, ranging from 8% in the WHO Western Pacific region to 24% in the Eastern Mediterranean region. Extrapulmonary TB, again, can be either primary at the site of initial infection or secondary or disseminated or diffused, which usually occurs due to hematogenous lymphatic spread of bacteria from the primary organ. So, as I mentioned, extrapulmonary tuberculosis, the bacterium can target any organ, no exceptions. Depends on what? It's still unknown why the bacterium targeting such organ. So it can target lungs as a pleural TB, central nervous system, abdominal TB, lymph node TB, and bone and joints. This diagram shows the pathogenic life cycle and extrapulmonary dissemination of tuberculosis. I'm not going to spend time on these details, but it is good to know that the TB disease starts with the primary infection, and the bacilli goes through the lymphatic dissemination and the hematogenous dissemination through the tubercular granuloma, through the hematogenous dissemination, and then it will target any organ in the human being. These are some numbers of extrapulmonary tuberculosis infection in Saudi Arabia. We have in 2021 almost 560 cases. This is a considerable number of extrapulmonary tuberculosis in Saudi Arabia. So it is worthwhile to study the physiology of the bacteria inside the organ. So what is the challenge? Why we are focusing on extrapulmonary tuberculosis in our research? Because of the possibacillary nature and the invasiveness of specimen collection procedures, extrapulmonary tuberculosis remains a diagnostic challenge. The gold standard of TB diagnosis, phenotypic techniques such as mycobacterial culture, we have two types of culture, liquid and solid cultures, is considered to be labor intensive and time consuming. It takes sometimes almost 10 weeks in solid cultures. And in liquid cultures, it takes up to 42 days, which is quite a long period. While smear microscopy, it's quite easy, piece of cake technology. It's quite basic, non-waved test and fast method of detecting M. tuberculosis bacilli. It is low sensitivity and negative predictive value, as well as the number of samples necessary limit its clinical effects. Evidence from previously published research indicated that traditional mycobacterial experiments such as microscopy and culture for pulmonary diagnosis and extrapulmonary could not be substituted by nucleic acid amplification technologies. We have a big problem with tuberculosis diagnosis. A few years later, however, expert MTB-REF, which was introduced by Cepheid medical company, modified this trend, showing 88% and 98% pooled sensitivity and specificity for the diagnosis of pulmonary TB specimens, respectively. However, data for the diagnosis of extrapulmonary TB using expert MTB-REF is still controversial and variable according to specimen types. Furthermore, some studies reported low sensitivity and specificity of this technology, expert MTB-REF, with extrapulmonary samples. For example, higher sensitivity to culture and composite reference standards have been recorded for cerebrospinal fluid, 79.5 and 55.5, compared to pleural and other sterile body fluids from 17 to 43.7%. These studies suggest that expert MTB-REF perform best with respiratory specimens. And this is what was mentioned in the WHO diagnostic manual. Because of the low possibacillary number of extrapulmonary TB specimens. Furthermore, in the company's user manual, it has been mentioned that this technology should be used and validated for respiratory specimens only, whereas the extrapulmonary specimens are released as offline use, which is a big problem. It should be validated in all countries to find out whether it is proper to be used with extrapulmonary tuberculosis. So what is this technology? The WHO officially endorses expert MTBRIF as the only rapid molecular test for the rapid diagnosis of TB. And WHO suggested the first use of expert MTBRIF testing in 2010 for pulmonary TB diagnosis only. Expert assay is a quick, automated, semi-quantitative, real-time PCR, cartridge-based assay that can detect MTB complex and its resistance to rifampicin. So, this publication was released a while ago by the Riyadh Regional Laboratory, and the aims of this publication to present it is a retrospective analysis and was conducted at Microbacteriology Reference Laboratory in Riyadh from January 2013 to July 2019. This study examines the diagnostic impact of the addition of expert MTBRIF as a routine test in the diagnosis of extrapulmonary tuberculosis in the reference Saudi Arabian laboratory compared to the gold standard phenotypic process and the microscopy. Specifically, the goal was to measure the number needed to diagnose and the clinical utility index of the assay in different non-respiratory specimen forms. It is the first study published in the GCC countries. Here is the research setting. Around 3,002 specimens were included in this study. 76 patients were excluded because of the insufficient extrapulmonary specimen volume reason. So we ended up with 2,935 patients, provided the list of specimens in front of you. The diagnostic techniques which were included in this study, including AFB staining, kininoid staining, midget culture, midget direct sensitivity testing, and expert MTBRIF. The table in front of you demonstrates the precision of expert MTBRIF and kininoid staining using the midget mycobacterial culture system as a reference method for the different EPTB samples forms and 2,935 specimens. This is a huge number of extrapulmonary specimens. The extrapulmonary specimens are very rare to be submitted to the TB laboratories. But this number is quite huge and supportive to our study. What we found, the table in front of you shows the type of specimens that were included in our study, and the left side of this table shows the expert statistics, and the right side shows the AFB statistics. It was found that the sensitivity of expert MTBRIF with pus and urine is very good. It reached 98% and specificity is 100%. The clinical utility index for both pus and urine is 0.8, which is quite good. Furthermore, the CSF shows a little bit good sensitivity and specificity. Before going to the overall, we can see that the tissue samples, the most important samples to be processed with this technology, showing quite low sensitivity, 75%, which is very low. And I will show the reasons behind that. The overall sensitivity and specificity is reasonably good. The sensitivity is 76 and specificity is 100%. So the size of a large sample of non-respiratory specimens increases the reliability of our study. This study shows that Expert has a high specificity in all non-respiratory specimens. This study concluded that tissue samples had the lowest sensitivity, about 75% of all extrapulmonary specimens. One of the reasons for this may be that the extraction of MTB bacilli from tissue mass is quite challenging. Sometimes the tissue is quite big mass is submitted to the laboratory. So it is quite confusing which part of the tissue we have to choose to extract the tubercle bacilli. So it is quite challenging. The low sensitivity of the Expert MTB-RIF in body fluids and tissue is believed to be due to the PCR inhibitors, and again, this is one of the reasons. A few years later, Cepheid released the Expert MTB-RIF Ultra. They increased the sensitivity on the cost of the specificity. So the next generation of Expert, known as Expert Ultra, was launched in 2017 to improve the performance of the Expert in smear-negative specimen for better detection of MTB and a higher limit of detection, about 16 colony forming unit per mil, which is very, very low amount of bacilli. The sensitivity of the Expert Ultra was increased by combining two new PCR assays targeting the multi-copy genes IS6110 and IS1081, a larger DNA reaction chamber and a transformation for the hemi-nested to the fully nested PCR reaction. So why was MTB-RIF Ultra developed? The old generation, the Expert MTB-RIF assay challenges, as shown, sensitivity in smear negatives and HIV-associated TB low, about 60 to 70% suboptimal, and sensitivity for rifampicin-resistant determination may miss some rifampicins. So the Expert Ultra assay was developed to address the challenges of diagnosing buccibacillary TB disease. These are some differences between MTB-RIF, the old generation, and the new generation MTB-RIF Ultra. So both detects rifampicin resistance surrogate for MDR-TB, whereas the old generation working on the single target RPOB core region, and the new generation working on multi-copy target RPOB core region insertion elements IS6110 and IS1081, and these are short copies of DNA occur multiple times in genome conserved in MTB complex. So this table shows how the results look like and differences between the old and the new generations. So with MTB-RIF, the old generation shows 5 results categories: not detected, high, medium, low, and very low positive results. Whereas the new generation shows the 5 categories plus the trace amount MTB detection, which works on very, very, very minimum amount of bacilli. So the result becomes trace call or trace detection. Again, we meant to do a new study to validate the Expert Ultra performance on extrapulmonary tuberculosis samples, because this technology is not endorsed by the WHO. It is offline use. So we have to validate this technology before apply it on extrapulmonary specimens. So our study included 845 extrapulmonary specimens. As it's shown in this graph. Routine processing of specimens received and tested using Expert MTB-RIF, the old technology, midget culture and canyon staining, plus the new technology. This study are divided into two phases. 140 specimens were applied or processed by all technologies, the four technologies, the old generation, the new generation, the culture, and the AFB staining, whereas the rest of samples, or all samples, are placed on 845 extra-preliminary specimens have been examined using only the expert ultra only. The gold standard to compare with is the culture. The culture in tuberculosis is diagnosis is always the gold standard method. The demographic data of the samples and characteristics are shown in this graph. So through this graph, we can see that the majority of samples with the age from 25 to 44 years old, and the majority of samples were submitted for males, and the majority were Saudis. This is the opposite than what I was expected. This bar chart showing the comparison of TB cases by age group and gender. We can see that in all age groups, the majority of samples were for male. This graph shows, this table shows the diagnostic performance of expert ultra and AFB compared with midget culture. This is very, very important table. It shows the performance of the four technologies. This is quite interesting because the positive test of expert is 10 out of 140, whereas expert ultra, it detects 16 out of 140. Let's go to the MTB culture. It detected 10 out of 140. So the expert ultra detected more than the culture detected. The reason is still unknown, and we are conducting a new research now to find out what's the reason behind that. The AFB, again, the AFB, and I always recommend, as the WHO recommended, the AFB is not proper to be used with extrapulmonary specimens, as I will show in the other slides. So, the sensitivity of expert is around 82% compared to culture. The sensitivity of expert ultra is slightly higher than the expert, and this is what I did expect. The specificity of expert is 99%, quite good specificity, whereas the sensitivity, the specificity of expert ultra is slightly lower than expert, and this what was expected because the higher sensitivity on the cost of the lower specificity of expert ultra. Again, this was interesting because I did expect there is a correlation between the time to positivity from culture and the categorization by the expert ultra. This is the category of the detection of ultra. But we found that there is no correlation between the time of positivity of culture and the categories of expert ultra. The p-value was 0.4. This is the core research of our paper. So this table shows the different types of sample used to validate the expert ultra technology. They are all non-respiratory samples. The left side of this table shows the expert ultra statistics, and the right side shows the AFB staining. We found that cerebrospinal fluid samples, gastric aspiration, pus, synovial fluid, and other aspiration fluid showing slightly good sensitivity and specificity. Specifically on cerebrospinal fluid, gastric aspiration, pus, and synovial fluid, they show slightly good sensitivity and specificity. If you remember, the table for the old generation shows quite low sensitivity for tissue samples. The sensitivity with expert ultra goes up to reach almost 80% for tissue, which is quite good. answer specificity is 91%. Again, pleural fluid shows higher sensitivity and specificity than the old generation. This slide summarizes the overall sensitivity and specificity between the Expert and Expert Ultra. It is shown that the overall sensitivity and specificity of the old generation technology is 76 sensitivity and 100 specificity, whereas the new generation Ultra shows higher sensitivity, 82%, and slightly lower specificity, 89%. So, in conclusion, results of this study provide evidence that the Expert MTBRF Ultra assay has higher sensitivity than Expert MTBRF with a slightly lower specificity. Our work has extended the diagnostic evaluation of Expert Ultra assay in non-respiratory samples and is the first assessment of Expert MTBRF performance in both adult and pediatric patients in the KSA. Traditional laboratory techniques such as microscopy for the diagnosis of extrapulmonary tuberculosis specimens are struggling from being sensitive as shown in this study. Prospective and large-scale research needs to evaluate the predictive role of these molecular-based assays in the clinical outcome and their cost effectiveness in the current healthcare systems. This is our publication. It was published on 14th of September 2023 for the people who are interested in tuberculosis. Thank you.
Thank you, Dr. Abdul Wahab. I think we'll leave the question later on. Now we're going to go to our second speaker. We are talking about Dr. Suad Al-Atiyya. Suad Al-Atiyya, she's of molecular microbiology. She's the head of the molecular unit in Prince Sultan Military Medical City. And she's going to present a lecture talking about the TB. Dr. Suad.
Assalamu alaikum. Good afternoon, everybody. And allow me, I'm very delightful and honored to be part of this session. Today I will talk about my presentation about my favorite subject, that transforming tuberculosis lab diagnosis. So the main objective of I think there's one slide before. نعم أمشي كذا في الأول. Yep. Okay. Thank you. Okay. About epidemiology, I think Dr. Abdul Wahab Jama, he's talked a lot about epidemiology, which is give us a good, clear idea. But despite all the effort by Global Health, still we have challenges, and with millions of new cases reported each year. However, it was considered as a deadly infectious until COVID-19 has been emerged. So there's a lot, it's increasing. The new cases has been increasing significantly because it's misdiagnosed during this pandemic. Today, what we have now, we have a traditional method which is still has a limitation. However, the timely timely and accurate diagnosis is crucial for effective TB control. Okay, so I'm going to talk about transforming what's going on and what's going to transform mutation of TB diagnosis. I'm going to talk the objective of transformative. So the objective of transforming tuberculosis to improve the four things: accuracy, speed, accessibility, and affordability of TB detection and diagnosis. This is the main objective, or the aim actually, for transforming tuberculosis diagnosis. I'm going to go through this one. I make it as a colorful objective to grab your attention and to make it is not boring. So starting with early detection, this is one objective of transforming. Early detection is very, that is mean detect TB cases and early stage infection, even without symptomatic or before it's become evident. This is very important. This is to improve patient outcome. The second objective for this transformative is increased sensitivity. As Dr. Abdul-Wahab told, it's sensitivity and specificity has become together. With increased sensitivity, the specificity has become lower than the sensitivity. But now we have to insert the technology that have higher sensitivity in TB lab, especially with extrapulmonary or pediatric patient or immunocompromised. The specificity is mainly for avoid the false positive result. Now, rapid diagnosis is one of the objectives. This is very, very, very important to have this kind of platform. We needed something to make it as a last one also. I think you have this like gene expert. We have detection. They have two integrated things. It's integrated detection of mycobacteria with with the multi-drug genes for mycobacteria, which is very important to improve outcome of the patient. Point of care testing, this is also objective, the transforming, that's what we are talking about it. Promote development and deployment of point of care diagnostic tests can be used in patient location. That's what we have to look for it, rather than to send it to the hospital if they are in some certain of health center, or to waiting for come patient again and take by nurses to the lab. It takes time. So it's very important to have this point of care. We have to look for this one. Affordability, that is make TB diagnosis is more affordable and accessible to people who in low resource area. This is also not only low source area. I mean, even in the border of the country or something like that, we have to make sure this one, minimize laboratory infrastructure. This is developing tests that require minimal laboratory infraction by training, by allowing widespread implementation. That's we have to look for this, and I'm going to talk about it. Integration with other health services. This is very important, integrating TB diagnosis with other health services such as HIV testing and maternal and child health program to identify co-infection. This is very important. Enhance surveillance, of course, strengthening TB surveillance through improved diagnostic tool to track the disease prevalence, trend, and hotspot of target intervention. That is one objective, one thing. Also, community-based diagnosis, engaged community and trained community health worker in the diagnosis TB, increasing cases detection at the grassroots level. I'm going to explain this in the solution, but that's what we have to engage the community by training the community and health worker, by a lot of education, reduce stigma. This is also one of what we face with HIV patient and tuberculosis. Promote the use non-stigmatizing diagnostic method to encourage the patient or individuals to seek testing and treatment without fear of discriminated, as it's happened sometimes in clinical. Research and innovation, encourage ongoing research. That's mainly for including artificial intelligence, biomark, new diagnostic tool. That's what we have to increase research in tuberculosis because it's still compared to other infectious limit. Policy and regulatory support, advocate for supportive policy and regulatory framework that facilitated the approval and implementation of new TB diagnostics. That's also this we have to connect to WHO for a lot of support policy. The last slide for objective, global collaboration. This is encourage collaboration among government, international organization, research, and the private sector to share knowledge, expertise, and resource of pursuit to improve TB diagnosis. This is very important. Reduction of transmission. Yes, this it will happen if we have a good diagnosis through the reduced transmission rate, through the early detection, prompt treatment, and effective infection control measurement. Contribution to TB eliminated, support the broader goal of TB elimination by reducing TB incidence and prevalence through improved the diagnosis and treatment. So that's the aim, actually, or objective of transform TB diagnosis from traditional, which is, as Dr. mentioned that before, it's laborious and time-consuming, but and limited that method, to more efficient, accurate, and accessible approach. This will be ultimately will eliminate of TB as public health threat. We cannot go further before I speak about challenges that we are facing in laboratory diagnosis of TB. As you see here, TB, first of all, is high infection, which is really pose biosafety risk for laboratory. That's why we have to make check about the medical profile, annually X-ray. So really, it's very dangerous. We have, and I think we have another lecture talk about the biosafety about this lab. Okay, and staff through the direct, because the problem with this, because the staff, they are direct, they are dealing with TB either direct with the sample, so it's very important with them TB. Collection sample, collection sputum sample from oral cavity, of course, because this is primarily as a primary specimen. We have used it for diagnosis of pulmonary infectious oral, because this sputum is coming through the oral, which is contain normal flora, so we have decontaminated, and this can be affect the viable of mycobacteria that around are found in sputum, which can be reduce the number if we are know about it, and also can be partially deactivated this organism, so it's going to delay to growth in the culture. Also, the specimen quality is very important. As I mentioned, pulmonary specimens and extrapulmonary specimens, sputum, tracheal, aspirate. As you can see here, you can see here, this is a saliva, and this is the proper sample, which is saliva is not really good sample, but that's what we need. And this is not everybody can reduce it, especially kids and very elderly patients. They cannot really give us the good sample, so they will go and face it for tracheal and pleural, either bronchial alveolar lavage. Slow-growing bacteria as one of problem or the issues in mycobacteria, it is very slow. The generation time for it is 8 hours for division for the sample. So as mentioned, if it's a positive smear as a mini, it will get it after 1 week. That is the minimum. And the maximum, especially with extrapulmonary, it can be between 8 or 9 sometimes if it's slow, especially with extrapulmonary. Growth condition, of course, as mentioned before, this is considered as a gold standard of TB, gold standard of mycobacteria, which is need to be supplement vitamins. Is not easy media to have it, and also we have to contain it must be found in special tubes that keep the humidity for it for long incubation. Of course, this is a big issue as a technician, as us a technician. We need skilled TB laboratory technician. Not everyone be able to be professional or skilled in TB, unless spend a lot of time to work with TB, because he need to learn how can deal with this hygiene which can be cause infection to the healthcare worker. So that's what we have, one of the issues what we have. So what suggestion to transformation tuberculosis diagnosis? Okay, now we have the suggestion. Transformation from traditional method, transformation, okay. Transformation from traditional method to advanced technology, molecular testing replace smear. Okay, there are some suggestions, they say, according to also by WHO, suggested using molecular testing replace to smear microscopy. That's what suggestion, and this is really, I think, is good to replace sample. But we have to be very careful. Not all, first of all, negative result of PCR is not excluding the infection. That's first things. And also, if it is negative for MTB, that does not mean there's no infection by other mycobacteria non-tuberculosis, like avium in HIV patients. So we have to be very careful and put these things under special guidance and regulation to when we are replace the molecular testing replace smear by molecular testing. And we have a good example as Gene Expert and other platform. Okay, enhancement of care testing refer to process improving and optimizing diagnostic tests and procedure that conducted as to near location. As I mentioned before, it's good thing that we have technology next or platform next to patient. This is the goal of make BOCT more effective, efficient, and accessible various healthcare settings. This is make easier for physician and patient. If he high suspected TB, he can use this platform to see, rather than after that. If it's come negative, they can send it to centralized hospital or lab. If it's positive, so he can initiate the treatment. Encourage molecular diagnostics, so we can use this benefit of using molecular. Encourage molecular tests by using molecular diagnostic by detection specific genetic sequencing, protein, biomarker diagnosis, disease, monitor treatment effectively. So that is what the good thing by molecular tests. It's easy to use it and modify it to what we are looking in this organism. Either we can using molecular marker, or protein or biomarker, all this one. So that's what we have to encourage molecular. Multi-disease testing must be replaced single test. Okay, what we have for example, for respiratory panel, we can detect four disease in one cartridge. So I believe in future we can have these things with TB, so they can include it integrated TB with HIV testing or TB, HIV, and COVID. That is good as a multiplex test, as rather than to send it for mycology, for bacteriology, for virology. It's better to use it in one cartridge, and then after that, for confirmatory, they can use the things. The third solution for this sample must be combined to or replace sputum. Okay, as I mentioned before, pediatric, elderly, very sick patients, they cannot send sample. From the COVID, we learned something. There are types of sample. Either we can use nasal aspirate sample, swab, or oral. Oral, if he's really sick, he can cough, so we can use it. Urine, also we can use it. But we have to look for other technique, or specimen can be replaced the traditional primary sample, sputum sample. That is make easy for the things for patient outbreak. Strength laboratory infrastructure. Strength laboratory by, as I mentioned before, improving the healthcare system and diagnosis, including tuberculosis, TB. That's what we have to mention. Reduce costs and increase accessibility. As I think it's better to have some, because not all the labs can be afford or things like have a very expensive reagent, so with high number of patients. So you're going to stop to use this reagent. You are going to look for another cheaper or less expensive than this technology. So it's better to use the things which is good to looking and advance this technology, which is less expensive and make it easy for everybody to use it. Address comorbidities and co-infection. That's what we said. If the patient HIV, especially with HIV patient, it's good to use this one. Individual with HIV is also, or diabetes or hepatitis, it's better to use also to diagnosis or to ask for diagnosis TB infection. Early case detection is critical, as I said, for initiated. It's good, it's important for several important benefits. Timely treatment, reduce transmission, preventing complication, lower mortality, reduce healthcare costs, and community protection. That is what we have to do. Prompting research, we have to encourage research. Why we have to encourage research? For the fighting TB against inefficient diagnostic, drug discovery, vaccine development, understanding drug resistance, and agreed therapeutic for this one. Community engagement, I think they have, it's like community engagement by educating them, like TB day, or by school, or what is symptomatic for TB, by education the people and in terms of a lot of institute. Policy, as I've said, supportive policy is enable environment for TB control. Global collaboration, the big example for this is Stop TB partnership. This is what is this doing, which is bring together government, civil society, private sector, and accelerate effort for TB. It involves collaboration between countries, international organization, and non-governmental organization to research, which is important for a world TB-free world. So I'm going to say example for this thing. As I mentioned before, point of care testing. This is the transition introduced suggestion for using VOCT means transform for TB. I think this is one of the big challenge for us. This is kind of some point of care can be used with TB. For example, lateral flow assays, they can use with urine, especially with kids, and this give this one of sensitivity. There's another, I will not go further for this one, but there's another technology. The main thing is like a gene expert or the BCR-based technology, and also for point of care ultrasound. That's all the things it can be used friendly with pediatric or with physician can be used these things. But the main things what they are recommended that is not invasive can be different types of base, like PCR or antibody antigen. It should be cheap, fast detection, drug resistant. That's, as you can see, not all of this can be drug, but there are 2 or 3 of this platform can be drug resistant, can be detected. Should be cheap, fast, and detection of drug, and the sensitivity not less than 66, and specificity must become at 98. Here, one of example for monitoring response for tuberculosis chemotherapy. Actually, we don't have right now what we have. We're using traditional method by smear after the patient has treatment for 3 months. He's coming, and we're doing smears and culture. Of course, it will become negative, and the culture will take time until to growing. But this is not really show me this is patient really clear from this infection or no. It takes time until you suggest is his continuing the treatment or no. So there's another option for this one. Molecular bacterial load assay is exactly the same viral load using with viruses by rapid molecular assay quantified mycobacteria. It can be in future replace the culture-based method. It is multiplex real-time quantitative PCR assay detecting 16S ribosomal RNA. Why this one? Because this gene is responsible about transcription of viral. So if it's this viral or can be transcript, so it's come high. If it's decline, that does mean he's response well. That is provide early information on the rate of decline. Bacterial load has technical advantage for culture. So you can see take is from patient. It's really is more accurate than culture-based method because I told you that can be detect the bacterial load in the sample. So the third example, the whole genome sequencing, and this is the trend I think is now. After a couple of years, it will be replaced. The method is a molecular technique used to determine the exactly sequencing of DNA particle. It can be conducted one step after you get the culture. Just one step, you can have your all the information you need. There are a lot of technology has from small Oxford from Oxford nanobore until Illumina products, all of the things. You can see this from sample preparation, library construction, next generation sequencing, bioinformatics. There's some of example, next generation sequencing, Illumina, Oxford nanobore, other things is can using whole genome sequencing. There's a lot, as you see from the workshop before. There are a lot. The company has been developed a lot of technology to come with next generation sequencing. Why we are, this is just only quick. You can see this is here is from culture. You just only extraction DNA. Then after the then after that shorting DNA by enzyme. Then after that amplification, you can use it for PCR using to amplify this what you needed. Then after the library, this is tagging the fragment by special sequencing and enter to the machine. It takes around the maximum, as I far know, 72 hours for sequencing whole mycobacteria genome. Then after that, give you raw read, which is this is go by bioinformatic can be analysis. This is the thing. If you using bioinformatic to help you to analysis result is mainly in college, in university, and things, but it's not really useful in diagnostic lab. So why we are using genome sequencing? What the benefit of genome sequencing? The benefit of genome sequencing, first of all, it can give you subspecies identification. It can give you subspecies level genotyping. It can give you also what lineage you have. As far as we know, we have 7 lineage. Around transmitted between the content. Why we have to know this one? Because there's some certain of lineage has already drug-resistant genes. For example, Beijing strain and Central Asian Indian strain are resistant. That's why we can see MDR are common there in Beijing and India. So it can be, and also it's good for us as epidemiological if you know what type of organism, what type of lineage you have. But it it's not really, because globalization and immigration and traveling is really all this lineage together. But at least you can know what the common lineage you have in the area. Antibiotic resistant, as I mentioned, that you can have it from gene you have. Investigated community outbreak, when you have investigated community outbreak, you can trace from the index, are this strain is coming from this index or no. So it's easier rather than to have, because as I said, it's monoclonal genome for TB, so it's not easy to using unless you are using the other genotyping, which is laborious and time consuming. This sequence from relapse and reinfection. Sometimes patient come after 1 year still has a TB. So you want to make sure this strain had the same before the strain or no. So either you can, if it's the same exactly 100, that is mean relapse. If it's different, sorry, infection. Mixed infection, some patient in endemic area, especially in South Africa or something, they can 2 or 3 strain, different strain is with his body can be affected by mixed infection. Management post-treatment, we can use this one by tracing is this the same strain or no. That is the good thing. That's what I feel. That's what we are using in diagnosing. We don't need like bioinformatic or IT to help us. There is a lot of software. When you have this, if you are do it as BCR, come next day and put the or read, it give you like this one. It just give you the drug, what you have here, sensitive or resistant, and also you have what type of you have and what type of lineage. This is a good thing with the genome sequencing. I think you don't need to do all the skilled people, all the biochemical tests, all the culture. You can have it. You can have it with one step after after one genome sequencing, after become positive with culture. So this is kind of comparison what we have, and I done it by myself, and I know it about it, I'm sure about it. So this is the time around by using the traditional methods. It take about 8 to 10. This is in high things by genotyping using in references lab. They can do genotyping, spologotyping, myro, insertion typing, that you can. So it takes around between 8 to 10. That's one. However, with whole genome sequencing from 2 to 4 weeks. This is different, 2 to 4 weeks. If it's bacterial, it will take 1 week maximum. But why I said from 2 to 4 weeks? Because we are waiting for culture. However, now there are a lot of technology can fishing the mycobacteria from the sample itself, but it's still under research. It's because the number or the size of the bacteria in the specimen, it doesn't give me good quality of DNA. So it's better to use it after culture. So my conclusion, the transform of TB diagnosis has made significant strides, offering faster, more accurate, and accessible method for detecting TB and drug resistance. While there are still challenges to overcome, as I mentioned before, it's not all they can do it. Continued effort of research, healthcare infrastructure development, and global collaboration are crucial to achieving the goal of eliminating TB as a public health threat. Thank you very much. This is my reference.
Thank you, Dr. Saad, for the good lecture talking about the TB. Now we're going to start with the last speaker, Dr. Saudi. And he's going to talk about the biosafety and biosecurity. Saud al-Shehri, the PhD in biological disaster from Cardiff University, and also MBA from King Abdulaziz University also, and also a master degree in medical and molecular microbiology. Dr. Saud.
بسم الله الرحمن الرحيم والصلاة على سيدنا محمد وعلى آله وصحبه أجمعين. السلام عليكم ورحمة الله وبركاته. I'd like to thank Dr. Abdulaziz Al-Kathiri for his invitation to attend this conference, and also many thanks for his team for cooperation and efforts. This is my outline for this talk, inshallah. According to many factors, such as lack of biosafety and biosecurity, we can have biological disaster, which is scenarios involving disability or death on large scale among human, animal, and plants due to toxins or disease caused by live organism or their products. Alhamdulillah, I have classified this classification for biological disaster, and can be seen here the lack of biosafety and biosecurity, one of the main factors that can cause the disaster. The spectrum of risks in the world is wide, but we can control them by biorisk management, which is divided to three subjects: public health and biosafety and biosecurity. I'll focus on biosafety and biosecurity in this talk. Biosafety and biosecurity have many definitions. Defined by many international organisms. So, and put your mind that biosafety, that how to protect yourself from the organisms, and the biosecurity, how to protect the microorganisms from yourself. Biosafety and biosecurity are complementary for each other, and they have, each of them has own elements or components. When we implement them in right way, we can reach the global public health security. Unfortunately, if they are destroyed or we have a lack of biosafety or biosecurity, we reach the bio risk for our community. The importance of biosafety and security have been increased in our day. So for biosafety, it's important to produce the guidelines to develop to be developed and to protect the workers in the lab. Whereas biosecurity, it's important to prevent the thief and misuse of pathogens. As the importance of these issues, many organizations produce a lot of guidelines, and also for COVID, the WHO produced the guidelines for biosafety for this disease. To control or to contain the biosafety or biorisks, the international organization such as WHO introduced the International Health Regulations, and United Nations Security Council produced the resolution which is 1540, which support the Biological Weapons Convention. We have to use the risk groups to classify the biosecurity, biosafety level. The first group of the first one, which is the agent that are not associated with disease in healthy adult humans, such as Escherichia coli. but still we need minimum safety measures like gloves and mask. The second group, which are agents that are associated with the human disease, but it's rarely serious, and it has a preventive and treatment for this disease, such as hepatitis B and hepatitis A, and influenza, measles, and dengue fever. The laboratory personnel can carry out diagnostic tests on this for the samples, but need to wear the gloves and face protection and gowns as well. The laboratory facilities are designed them based on four levels: biosafety level 1, biosafety level 2, and biosafety level 3, and biosafety level 4. This table illustrates the biosafety level here, and the type of labs here, and the practice that you have to do, and the safety equipment that's required. This slide shows the requirement for each biosafety level, and according to the last presentation, I tried to apply the requirements here according to tuberculosis, which is from risk group 3. And easy to see here that it's mandatory here and desirable some of the requirements, whereas the fourth, our level safety level 4 needs all of them. All of these requirements are mandatory. Risk factors, we have to consider about the factors here and apply it for the risk groups that we have. Pathogenicity here, it's long for Mycobacterium tuberculosis complex. I take it as example. We see here this it has long period here, and infectious dose, it is small amount of bacilli that can affect or can cause the disease. That way of transmission, it's easy to transmit it from person to person by air. Survival, it will to stay for a long time, and the availability of the treatment and the protection there. The geographical localization, it is worldwide. This slide shows the personal protective clothing and equipment that may be used by staff in the labs. For biosecurity safety, we have to consider some factors or to use in the risk assessment. The bacterial load of materials the possibility of material handled to generate infectious aerosol during the different procedures, establish high-level precaution and biosafety measures, epidemiology of the disease and the patient population, health and immune status of laboratory workers, that we have to make sure they taken the vaccination, experience of lab staff using a good laboratory practice. We have to make sure they understand the policy procedure for the biosafety inside of the lab. Equipment biosafety features required to prevent the spill packages aerosol generation when handling potentially infectious material. Maintenance of equipment, it's important, and biomedical waste management, it's more important as well. Essential biosafety measures for the lab. Codes of practice, which describe the practice policy procedures inside of the lab. We have to consider about the lab access, responsibility of the lab manager, personal protective equipment should be procedure and work areas. Equipment design should be designed to prevent limit contact between operator and infectious material, constructed of materials that are resistant to liquid, fabricated to be smooth and without sharp edge, easy maintenance, clean, decontamination and certifications testing in the lab where the risk of infection is considered to be moderated or high. The BC or the biosafety cabinet provided the primary containment of infectious aerosol generated by certain procedures. When you design the lab, we should go through all these recommended features for the lab. The training, it is the most important, essential for biosafety and biosecurity as well. We have to train the people or the worker who come to the lab and make sure they have a good training to avoid any accident, la samah Allah. This is the cabinet. I'm sure that all of you know the cabinets or for biosafety cabinets and the importance of all of them in our lab. Biosecurity, it's important to do the biosecurity risk assessment based on identify the assist, identify the threat, identify the facility vulnerabilities. Pillars of biosecurity, the most important for us is physically biosecurity to prevent the risk of or to prevent unauthorized access to the people to go to the lab or the building or a storage area. Also, the physical security measures include the locked lab doors, locked building doors. We have to use the biometrics or ID badge. Personal security, as we said before, the employee security training for a new employee, and evaluate the trust level by integrity of individual, good characteristics and restricted areas to lab area, and it's we have to list the employees who have access to a restricted area, and we have to before send them to this area, we have to check the police background and personal references. Information security, password protection of computers and files is the most frequent information security measures. Protect sensitive information, data, security plan, access control, agent, and written security policies practice, and data access limited for the official use only, restricted for the classified data only. The transport security, Dr. Lataybi in the last session, she was talking about that the sample, how to transfer it from area to area, and what the reason or the sequences of that can give a wrong treatment for the patient, or she's looking for the safety or patient safety. Here, it's important for us to carry the samples from a part or from the lab to the building or to our outside of the building or the hospital in the right way and to keep it in the safe way. The transfer of infectious substances between rooms, department, or labs must be blended to protect workers. This should be in our policy and procedures for biosafety and biosecurity guidelines in the lab. The shipment of infectious material must be adhered to safe packaging, documentation, and transport. And there are 9 classes of dangerous goods. 3 are important shippers of infectious substances, class 3, flammable liquid. But the most important for us is class 6. And under class 6, we have class 6.2, which is infectious substances, which is classified in 3 classification: infectious substances, biological substances, and biological products. Here, the packaging instruction and packaging specifications that we have to make sure that triple packaging, primary and secondary out containers are there, and we have to follow the instruction of in 602 and instruction of 650, and we have to mention the United Nations approved packaging. As I said, we divided into category A and B. For category A, should be ensure the box has United Nations certified marking, which is ensures it's certified by shipping category A. Use packaging large enough to accommodate all marking and label without overlapping. Don't consolidate infectious agent. Categorize category A, infectious substance affecting human with other infectious agents. For category B, it's the same, just without any. We don't know. Doesn't require the United Nations certified box. The key message that I like to deliver to you: be safe, to keep our committee safe, understand that needs to be protected, apply highest security to the most critical assist employee, a level security approach, reduce risk to acceptable level, and obtain strong management support. As I said, this is in the first slide that I show the biorisk, or spectrum of biorisk. If we working together with transparency, we will minimize the impact of the left of the spectrum, and we can reduce the possibility of the right of this spectrum. Thank you for your attention.
Thank you, Dr. Saud. I would like to see if we have any question for the speakers. Okay, since we don't have anything, I think it's better to close our session for today. And inshallah, we'll see you inshallah tomorrow. Takrim? Yeah. Dr. Abdulaziz Kathiri is the president of the Saudi Society for Medical Censor from Majma University, and he's going to give the awards for the speaker. Okay. Our first speaker is Dr. Abdul Wahab من جمعة. خلاص خلي مشكلة هذا خلي شو عبد الوهاب. سوري.
الله يعطيك العافية دكتور. شكرا.
Our second speaker is Dr. Suad Al-Atiyah. Our third speaker is Dr. Saud. Our last trophy is for me, Dr. Abdurrahman.
دكتور عبد الرحمن سليمان.
Thank you for all of the audience who gathered today and also the people who's online, and hopefully to see you inshallah tomorrow morning inshallah for our last day. Thank you.